Wow, what a nice lecture, and what a knowledgeable thing Sir has told us. Now, moving towards our next lecture, that is by Dr. Sumit Astana. He is HOD in Era Medical College, Lucknow. He is going to discuss about the future advancement in physical therapy treatments. Over to you, sir.
Hello everybody, here Dr. Sumit Asthana, head of the department, ERA University, ERA Institute of Allied Health Sciences and Research, is here signing in now for my lecture on the topic Future Advancements in Physiotherapy. So, first of all, I want to welcome all of you who are attending this wonderful and great fame conference, upcon, which is in combination with Physio nexgen conference. And I want to thanks to Dr. Sudeep Saxena, Dr. Sanjay Shukla, Dr. Rahul Parashar and Dr. Renu for making this wonderful combined platform this year and the time of pandemic for all of you to learn from your home or your college or easily through online, and we can connect with our visions with all of our students hearing to us. So फर्स्ट ऑफ ऑल मैं सबको नमस्कार कहता हूँ और ये बोलना चाहता हूँ कि डॉक्टर सुदीप सक्सेना सीनियर फिजियोथेरेपिस्ट ऑफ लखनऊ, डॉक्टर संजय शुक्ला सीनियर फिजियोथेरेपिस्ट ऑफ लखनऊ, डॉक्टर राहुल प्रकाशर माय dear junior and friend from Mathura, and Dr. Renu from Delhi. They all are wonderful physios and the dynamic physios, and they are the organizers of these conference, and they are doing such a marvelous job that they are making a platform, and they are just coming up with a platform in each and every year with the new advancements and new technologies, and even in this time of pandemic they are doing so much for our students and upcoming physio, so that they can learn from all of us. And as I have seen the flyers and posters, there are so much wonderful physios are here to provide their lectures, and they are doing such a marvelous job in their field, in their area. So many are so much seniors to me, so many are juniors to me, and so many are my colleagues, and all of them who are as a faculty of this upcon Physio nexgen conference are wonderful personalities. Okay, so I just want to start with my topic. So my topic, as I have already told, the topic is future advancements in physiotherapy. So when I talk about, the first thing I want to just discuss with you all is that मैं एक बात बोलूँगा कि जब से मैं इस फील्ड में आया और मैंने जो इतना समय गुजारा है, उसमें मैंने बहुत सारे चेंजेस देखे हैं फील्ड में, एंड दिस इज बिकॉज ऑफ such a dedicating team of physios here already working for our profession in a right path as the best as they can. And the thing what I want to start with this, the first thing is that the practice of physiotherapy has changed a lot in recent past, from using the movements as treatment means to the effect of microgravity on human body system, and integration of knowledge from development of pain science with changing facets of rehabilitation, along with uses of ultra modern technical support in motion study and electrotherapy itself, with integration of ergonomics and artificial limb and robotics research in rapidly changing the scope and limitation of physiotherapy practice. So, but these are not the only updation. Beyond that, we are working so much on. So, my topic is representing what till this date we have done in our field, and what the updation, what the recent advancement has been done in our field. I'm talking about for future also. And that what I was here, I was planning from so long time, and I have collected so much data with me about what we can do and what we can suggest our student to do in future. We can give a guideline to them to for the bright future of physiotherapy. And some emerging fields are there, and they are already like, if we talk about the medical trade, so in the form of trade, physiotherapy in foreign countries is just like APTA also. It is containing the second position in the medical trade. So why not in India? And they are just, even we are going with so much researches, even not in other medical field, these so much researches are going on, but we are already doing so much researches. And myself, I am also working so much for this future advancements. In future, if there may be availability after the pandemic, if there availability of workshop, I can take workshop on these techniques also, and future advancements also. But the thing, just now I want to share with all of you, not so much in the detail, because it is a video lecture, and for the online this conference, just now I want to just give you my vision, and just want to share my ideas or thinking or my thoughts related to advancements in physiotherapy. So I am here to talk to you about that only. Like that, if we talk about, like, physiotherapy is evolved a lot since its beginning era. Earlier it was a part of rehabilitation, where merely two broad sectors, namely electrotherapy and exercise therapy. However, with time changes, there have been many namely and other sectors of interest in field of physiotherapy. The purpose is that only to sum up with advanced technologies to reduce the time, efforts of physios, and do some best for our patients, either in the form of diagnosis, assessment, or treatment itself. The other thing, so if I generalize in a generalized way, list up the things in front of you. So one is, first, if I talk about the list till now, recent advancement, then first is movement based physiotherapy, which is called as manual therapy. Now current days, we have so much in advancement with physiotherapy, even so much other alternate therapies and alternate medicines are evolved with physiotherapy, and itself we are doing a marvelous job with manual therapy or movement based physiotherapy, like chiro, manipulation, manual therapy. So much things are there. Previously, if we see that only Maitland and Mulligan concept are there, then MWM, mobilization with movement, addresses by physiotherapists. Then after that, now so much are there advancements, and even alternate therapies like called chiropractic and osteopathy. These are also some of with physiotherapy, but we have to hold our reputation. So for that, this lecture is not here, but that we all have to keep mind that all have to come up with physiotherapy. But the broadly name is always physiotherapy for all of us. Now, next in the list, if we talk about the other system, is weightlessness. We are doing so much job, so much advancement, so much researchers are already come up with this 1 minute list. In the list of advancements in physiotherapy, second is effect of weightlessness on our body system, is a very recent field of study in the field of physiotherapy. It has been found that loss of muscle strength and mass is more rapid if the person spends long duration in weightlessness, that is without the effect of gravity. so that the loss of muscle strength and mass is more rapid if the person spends long duration in weightlessness, that is without the effect of gravity. This ongoing field of the research is concentrating to the astronaut returning from the space and on deep sea divers who spend long time in the absence or in reduced gravity environment. So let's see that what so much emerging thoughts are here to come sum up with physiotherapy, and we can do so much work in future also. Third in the list is pain science and integration of vast emerging body of knowledge in this field that affect the practice of physiotherapy in past couple of decades. Sometimes the development in pain science and its understanding refers as pain evolution, pain revolution. Pain has evolved from just a sensation to a perception and experience with time. So much work is going with pain science also. Now, ergonomics. What my one favorite lecture is always, I always used to take the lecture on. You all know so much advancements are going up with, and ergonomics, now ergonomics already involved in the curriculum of physiotherapy also. After that, sports physiotherapy and exercise rehabilitation. These all things are introduced in the modern advanced way. Other than that, biomechanical, 6, if we talk about further, biomechanical study and analysis of human motion. Log, each and every human motion we can analyze, and that help in the even gait analysis also, and that help for the best assessment for to make the best protocol of particular disorder or disease. Other than that, after that, if we talk about that is another emerging field in the artificial limb and their training also, and in that also robotic is very advanced technique. After that itself, if we talk about robotics is the advanced thing. Robotics, physiotherapy and rehabilitation, these the thing is very much involved current days in the physiotherapy. After that, if we talk about advanced electrotherapy, so much like mattress rhythm therapy, laser shock wave therapy, microwave therapy, so much advancements, and in future we are going with functional electrical stimulation, so much advancement in neuro rehabilitation. So much advancements are already going up with. So new development in future will make the field of medical science more evidence based, more scientific and more objective. So this is the main concept for the this is the for new visions to involve in the physiotherapy, that we can become more evidence, more scientific and more objective, and these things will have definitely for upgradation of physiotherapy fraternity and reduce the effort of physiotherapies. At a time we can see so much patients, okay, and with ease and with all of the things involving to upgrade the protocols or treatments of the patients we are giving. Okay, so if we now in detail, if we talk about the further advancement, so what I want to talk about the future advancement mainly, which I want to share with you, is the upcoming future advancement, which is artificial intelligence. If I just want to share some words, if there is 8 p.m. I am sitting in my home and I am in my on my sofa or my bed with my I am in a relaxed position. I've just watched the video my patient uploaded there that he is doing high stepping gait, okay, for an example, and viewed the image they sent to their मीन्स उन्होंने अपनी जो इमेज हमें भेजी, हमने जस्ट उसको देखा. सो द डायग्नोस्टिक बॉट, जो सॉफ्टवेयर हमने तैयार किया है, डायग्नोस्टिक सॉफ्टवेयर, वो ऑटोमेटिक नोट्स जनरेट करेगा व्हाट द आर्टिफिशियल इंटेलिजेंस कैन डू, एंड दे प्राइम्ड अप विथ ऑल द थिंग्स, एंड दे विल गिव a list of differential diagnosis, okay, on that virtual basis itself. Okay, I am in relaxed. at night, but I can treat or suggest or consult patient at that time also. That makes the ease of physiotherapy. And now, after that, notes and diagnostic boards, when I come up with differential diagnosis, I can easily able to communicate with virtual consultation from my home itself with the patient, and this will be the future of physiotherapy. Like today, you just want to book the flight ticket, and like in Go I Go for an example, and if you have missed up, if you have some problem, you want to share your problem, there Jia is a messaging app joined with that. This is what artificial intelligence, that all talks about my problem, okay, and the person is not there, that is the software is talking with us, and that is the bot which is talking with us. So this is the thing what we want in the future of physiotherapy. No doubt, this is the important thing, that manual presence or physical presence of physiotherapy is in the front of patient will do more and more better job. But for some circumstances and for ease of physiotherapy, but not always, we can do with more advancement in artificial intelligence physiotherapy, and we can come up with more and more technology based treatment for the patient, and we can satisfy the patient, and the knowledge by machine which I want to say to patient is exactly delivered by that machine and to patient, and patient already gets satisfied by that only. Like if we talk about AI, 1 minute. Yes. So what is AI? The term AI describes a computer's ability to perform tasks normally requiring human intelligence. That is machine learning. That is machines that can think. Machine learning is a field of study that gives computers the ability to learn without being explicitly programmed. AI systems that think and learn as humans do are same way off, but they can be a tool to assist in the analysis of healthcare data. So, if we go for future of physiotherapy, like in just now, we are already dealing with range of motion. If we want to diagnose or assess the patient and their range of motion get limited through a surgery, as already know, and for that treatment, surgery or plaster or after fracture, automatic tracking of ROM can be done. And what the benefit of that, अगर हम गोनियोमीटर यूज करते हैं तो गोनियोमीटर मूवमेंट के साथ लिमिट करता है कहीं ना कहीं रेंज चेक करने में, लेकिन अगर हम ऑटोमेटेड ट्रैकिंग थ्रू एनालिसिस रेंज ऑफ मोशन की करते हैं फॉर एन एग्जांपल, तो इट विल गिव द बेस्ट रेंज ऑफ मोशन रिजल्ट. For an example, I am telling you. So this will give you the best result, and after that you can set up best protocol to correct the ROM range of motion. This is just an example, and it is already going on with advancements in physiotherapy, and people are using this artificial intelligence machine learning for range of motion, to check range of motion, and so many progress are being going on. करेंटली द रिकमेंड है, आजकल हम देखें तो हमारी अप्रोच है कि हम गोनियोमीटर से चेक करते हैं, पर उसमें एक्यूरेसी की प्रॉब्लम कई बार आती है. तो हमारे पास दूसरा सॉल्यूशन है कि हम पेशेंट को वियर सेंसर्स प्रोवाइड करें. उसको हम सेंसर्स बॉडी में जो भी हम वेयरिंग एरियाज हैं या क्लोथ्स
Okay,
हैं या
moving towards our
हेड
next
ट्रैकिंग मशीन
lecture,
आई
that
ट्रैकिंग है
is
उनके
by the
साथ हम
Chancellor of
सेंसर्स को यूज
Gandhiram
करें और सेंसर्स के थ्रू हम
University,
उनके रेंज ऑफ
HOD
मोशन को चेक
Ahmedabad
करें उससे हम
Apollo
एग्जैक्ट
Medics,
पेल्विक
that
टिल्ट
is
पता कर
Dr.
सकते हैं,
K.N.
एग्जैक्ट
Annamalai
लैटरल टिल्ट
sir.
पता कर सकते हैं,
He is
एग्जैक्ट
General
एंटीरियर
Secretary.
टिल्ट गोनियोमीटर से इंक्लाइनोमीटर से आप उसमें एग्जैक्ट नहीं पता कर सकते, पर थ्रू एनालिसिस सेंसर्स आप यूज कर सकते हो एंड आप आर्टिफिशियल इंटेलिजेंस के थ्रू मशीन के सेल्फ ही आप पेशेंट को दूर बैठे कमांड भी दे सकते हो कि उसको एग्जैक्टली करना क्या है। पेशेंट आपके कम्युनिकेशन में नहीं है, पास नहीं है, फिर भी आप इजीली हैंडल कर सकते हो अपने पेशेंट को। तो ये बहुत बड़ा बेनिफिट है आर्टिफिशियल इंटेलिजेंस का। जैसे इसका प्रीवियस फॉर्म है टेलीमेडिसिन, जो ऑलरेडी हम यूज करते थे टेलीमेडिसिन। हम वहाँ पे मोबाइल एप्स बहुत सारे हैं, जैसे हम हार्ट रेट चेक कर लेते हैं मोबाइल के थ्रू। दीज ऑल आर अपकमिंग विद द यूज ऑफ आर्टिफिशियल इंटेलिजेंस। तो व्हाई नॉट इन फिजियोथेरेपी? फिजियोथेरेपी हम टूल असिस्टेड, हम अपने सॉफ्टवेयर से क्यों नहीं बना सकते जहाँ पे हमें ईज हो और फिजिबल सॉफ्टवेयर पे अगर हम वर्क करते हैं, रिसर्च करते हैं। सो दिस इज द फ्यूचर ऑफ फिजियोथेरेपी। लाइक द अदर थिंग इन न्यूरो रिहैबिलिटेशन, देयर आर सो मच एडवांसमेंट्स इन गोइंग ऑन। The two things we are going with neuro rehabilitation. Most of the neuro rehabilitation is that only that if we talk about the neuro rehabilitation advancement, so the two things, therapeutic robotics. Therapeutic robotics is the main part today in the today scenario for the neuro rehabilitation. If you use therapeutic robotics or robotic therapy with the patient of neurological disorder, we will definitely get so much good outcome in the shortest time. And other than that is functional electrical stimulation. So that is also a great thing we are going up with, and these things we are already using. Other than that, if we talk about more advanced techniques, so that is virtual reality. एंड वर्चुअल रियलिटी उसमें बहुत कुछ हो रहा है, बिकॉज न्यूरो में हम बात करते हैं तो ऑल द थिंग्स वी आर इंट्रोड्यूसिंग एंड वी आर डूइंग इन फ्यूचर एडवांसमेंट इज दैट द ट्रीटमेंट शुड बी विद न्यूरल प्लास्टिसिटी हो रहा है, बिकॉज न्यूरो में हम बात करते हैं तो ऑल द थिंग्स वी आर इंट्रोड्यूसिंग एंड वी आर डूइंग इन फ्यूचर एडवांसमेंट इज दैट द ट्रीटमेंट शुड बी विद न्यूरल प्लास्टिसिटी and neural plasticity based treatment is always being effective. and उस पर मैं आज बात नहीं करने वाला हूँ, लेकिन डिटेल में अगर हम बात करना चाहेंगे तो हम उन सब चीज को इंक्लूड करेंगे। तो आर्टिफिशियल इंटेलिजेंस, वर्चुअल रियलिटी, फंक्शनल इलेक्ट्रिकल स्टिमुलेशन, थेरेपेटिक robotics, these all things can be summed up with neural plasticity also, and so many other things like range of motion is the one example only for musculoskeletal disorders. Many more can come up with, many tool enabled artificial intelligence we can come up with. So we can do so much researches in that. So artificial intelligence is the future boom of physiotherapy, and it will definitely give so much advancements and so much benefits to physiotherapy. I can bet for that only. And if you, but already so much negative points are also there, like in artificial intelligence investment may be like augmented reality, virtual reality. We want to establish good and physiotherapy environment, clinic environment, we have to invest more. So this is the problem is that, but that can repay you in the future also. And if we come up with artificial intelligence, machine learning, softwares, mobile apps, and distance, so we can reduce the efforts of reaching to patients and home visits and so much population in that. We can reduce that, we can control the traffic of patients in your clinic with artificial intelligence. So if there is, means already each and everything include positive and negative point, but we, for future advancements, we always go up with, we have to go up with positive part of each and every technology, and we have to be technology enabled in future as a physiotherapy, because each and every healthcare sector and medical science is going up with technology friendly. So why not we physiotherapists can do such a great work by using technology? What the benefits to the patient we can get? Full access to the system containing records of all interaction with health and social care team. Full body analysis that highlights full body and true analysis. हम टूल से उतना इफेक्टिव वैलिड मेजरमेंट नहीं कर पाते जितना हम एनालिसिस और इसके थ्रू कर सकते हैं, वियर सेंसर्स के थ्रू कर सकते हैं, एनालिसिस के थ्रू कर सकते हैं. तो सो फुल बॉडी एनालिसिस दैट highlights areas of concern and suggest areas for improvement to health and well-being. Access to evidence-based diagnostic. मेन पार्ट आर्टिफिशियल इंटेलिजेंस और इन सब न्यू टेक्नोलॉजी का ये आएगा कि हम एविडेंस बेस्ड प्रैक्टिस कर सकते हैं और डायग्नोसिस, डिफरेंशियल डायग्नोसिस हमारे पास खुद इजीली बन के आ जाएंगी. सो हमारा काम बहुत इजी हो जाएगा. We can already prepare the diagnostic algorithms. Algorithms will support with the form of software, and we can reduce the effort of us in the making the best protocol for the treatment and best diagnosis and assessment for the patient. Prompt to take and upload appropriate pictures or video of their symptoms. We can easily take the video and pictures. Even not we are taking, if we are seeing other patient, our software, our bots are already taking their videos and picture, and our work will definitely reduced. Optimize care and patient safety. वहाँ पे patient safety और optimized care भी होगी. In this time of pandemic, जहाँ हमारा काम रुक गया 2-3 महीने, हमने क्लिनिक पे नहीं बैठे, हमने पेशेंट नहीं देखे, वहाँ अगर हमारे पास आर्टिफिशियल इंटेलिजेंस जैसी सुविधा होगी तो हम डेफिनेटली अपना काम फिजियोथेरेपिस्ट का कभी भी बंद नहीं होगा डे एंड नाइट. एंड जब हम टेलीमेडिसिन को यूज कर सकते हैं फिजियोथेरेपी में, तो हम काहे नहीं उसे आर्टिफिशियल इंटेलिजेंस से और अपग्रेड कर सकते हैं. क्यों न्यू एल्गोरिथम के साथ, क्यों न्यू सॉफ्टवेयर्स के साथ हम अपनी टेक्नोलॉजी इनेबल्ड कर सकते हैं अपने को, और बेस्ट टू बेस्ट एनालिसिस, बेस्ट टू बेस्ट डायग्नोसिस एंड बेस्ट टू बेस्ट ट्रीटमेंट प्रोटोकॉल विद प्रॉपर डोजेस हम इंट्रोड्यूस कर सकते हैं पेशेंट को with our easiness, with our reduced efforts. So this is my future vision among all of you and other than. So today I have talked to you about in short, because in lecture I am not come up with, but in workshop at the time of I can demonstrate you about this. I have so much data with all these things, and I'm just doing so much work in this area for future of physiotherapy. And if I will get a time and area, I will definitely represent these things among all of you with the vast knowledge. So one thing is artificial intelligence, where we correct range of motion. We can do neural plasticity based treatment. Machines learning we involve, we can do best analysis through AI, artificial intelligence. Other than that, ergonomics, already we are doing that. So much advancements are going. If we talk about VR and AR, augmented reality and virtual reality, that already have a vast topic and so much advancement with neuroplasticity based treatment is going on. So I am not going so much deep inside that today. I am just briefing all the things. Other than that, if we talk about neuromechanics, is the advanced. In future, I will talk about that only. Neurobiomechanics, neuroergonomics. These are, I am doing work on these also. But not this time. I can explain all the things to among you because it will take up so much long time. Because if I didn't get that detailed among you, then not so much that will stimulate your mind. One other thing, these न्यूरल प्लास्टिसिटी बेस्ड हम लोग पहले से कर रहे हैं. कोमा स्टिमुलेशन प्रोग्राम हम पहले से नहीं कर रहे हैं, जहाँ पे हम ऑडिटरी स्टिमुलस देते हैं कोमा के पेशेंट को, डेलेरियम वेजिटेटिव की, उसको टेक्टाइल स्टिमुलस देते हैं, उसको टेस्ट स्टिमुलस, गस्टेटरी स्टिमुलस देते हैं. उसको विजुअल स्टिमुलस देते हैं उसके जानने में। तो ये सारी चीज़ों को हम अगर टेक्नोलॉजी फ्रेंडली करते हैं तो बहुत सारी चीज़ों को हम इम्प्रूव कर सकते हैं। तो बहुत सारी चीज़ें जहाँ पे मैं कहना चाहता हूँ कि वी हैव टू कम अप विथ टेक्नोलॉजी इनेबल्ड system. Okay, so this will help us definitely. Other than that, one other topic advancement is come up with that already going on so many countries, but we have to work on that, and that is also a very good topic. That is postural restoration. We always talk about postural rehabilitation, postural assessment, postural treatment, but what is postural restoration? It is the unique type of physical therapy that addresses body's postural position and potential muscular imbalances which lead to pain. When properly positioned, aligned and balanced, the joints and muscles can work in a more effective and efficient manner. So हम लोग पोस्चरल रिस्टोरेशन जहां हम स्पोर्ट्स में और बहुत सारे सेक्टर्स में यूज हो रहा है, जिसमें हम प्रॉपरली बैलेंस्ड, अलाइंड और पोजीशनड पेशेंट को प्रॉपर ट्रीटमेंट देते हैं, तो उससे हम और इफेक्टिव ट्रीटमेंट दे सकते हैं। और उसको बैलेंस्ड पोजीशन अलाइंड बनाने के लिए हम उसको पहले प्रॉपरली एनालाइज करके देन हम उसकी मसल इम्बैलेंस हो, चाहे पेन हो, चाहे उसके पोस्चरल करेक्शन हो, कोई भी चीजों को ट्रीटमेंट दे सकते हैं। सो पोस्चरल रिस्टोरेशन एक इंस्टीट्यूट भी है जो इस पे काफी काम कर रहा है। और अगर हम उसको अपने फिजियोथेरेपी में प्योरली एडवांसमेंट्स को इंट्रोड्यूस करते हैं तो हम, और इसमें भी हम आर्टिफिशियल इंटेलिजेंस हम कहीं भी ला सकते हैं। देयर इज अ नो लिमिटेशन फॉर सॉफ्टवेयर बेस्ड treatment or machine based treatment. What we think, what that machine think at that time only, at that time of treatment, that machine will give you proper analysis of proper videos, proper picture, and easily you can analyze and you can set a best to best protocol, and you will come up with best outcome measures for to check the time to time prognosis. As already important is ईच एंड एवरी सेटिंग ऑफ ट्रीटमेंट, हम लोग बोलते हैं अपने स्टूडेंट्स को भी कि ईच एंड एवरी सेटिंग ऑफ ट्रीटमेंट बाय अ फिजियो हैज टू बी कम अप विद प्री एंड पोस्ट असेसमेंट, तभी हम उसको एक अच्छी प्रोग्नोसिस और एक अच्छी रिकवरी तक ले जा सकते। वी कैन कम विद गुड प्रोग्नोसिस ऑफ पेशेंट। सो हर जगह पे आर्टिफिशियल इंटेलिजेंस है। पोस्चरल रिस्टोरेशन की एक अपनी इंपॉर्टेंस है। न्यूरो एर्गोनॉमिक्स एक एडवांस अलग इंपॉर्टेंस है। न्यूरल प्लास्टिसिटी बेस्ड ट्रीटमेंट पे हमें और जाना चाहिए। वर्चुअल रियलिटी को इंट्रोड्यूस करना चाहिए। ऑगमेंटेड रियलिटी को लाना चाहिए। आर्टिफिशियल इंटेलिजेंस मेन फ्यूचर एडवांसमेंट है फिजियोथेरेपी में, जितना मैं अभी कोशिश में समझा पाया हूँ। और मैं कोशिश यही करूंगा कि आगे भी मौका मिला तो मैं और इसमें डिटेल आके आपके पास लेके आऊंगा। बट मैं अगर इसमें और भी बोलूं तो और बहुत कुछ है बोलने को, लेकिन बहुत सारी चीज जब तक आप उसको अब आर्टिफिशियल इंटेलिजेंस मैंने एक चीज आपके सामने रखी है, इसके साथ अब एआई इनेबल्ड रोबोटिक्स भी दे सकते हो। रोबोटिक्स को भी आप एआई इनेबल्ड कर सकते हो। जो रोबोटिक ट्रीटमेंट आप देते हो, बहुत सारे आपको पिक्चर्स मिल जाएंगी। यहाँ मैं क्योंकि वीडियो शूट कर रहा हूँ, मैं अभी कोई पीपीटी लेके या कोई लेक्चर लेके नहीं आया हूँ, बट आगे मौका मिलता है तो मैं वो सारी चीजों आपको डेमोन्स्ट्रेट भी कर सकता हूँ एट द टाइम ऑफ डिटेल वर्कशॉप एंड लॉन्ग लेक्चर, तो मैं आपको वो भी बता सकता हूँ। और अगर मैं पोस्चरल रिस्टोरेशन की बात करूँ तो अगर हम इस पोस्चरल रिस्टोरेशन को हम ऑक्यूपेशनल डिमांड के साथ बहुत फ्रीली हैंडल कर सकते हैं। रेस्पिरेटरी ट्रीटमेंट में ब्रीथिंग मसल्स को इम्प्रूव करने के लिए पोस्चरल रिस्टोरेशन बहुत इंपॉर्टेंट है। पेल्विक बैलेंस को, स्टर्नम को, ईच एंड एवरी कंपोनेंट, ईच एंड एवरी पार्ट को हम बेस्ट टू बेस्ट ट्रीट कर सकते हैं पोस्चरल रिस्टोरेशन के साथ एंड विद ऑगमेंटेड आर्टिफिशियल इंटेलिजेंस के साथ। रोबोट की अगर हम बात करते हैं तो रोबोट कैन असिस्ट फिजियोथेरेपी ड्यूरिंग द पैंडेमिक ऑल्सो। द ग्लव ऑफ द लाइक, जो हम रोबोटिक ग्लव्स यूज करते हैं, रोबोटिक एक्सोस्केलेटन, ये हम पेशेंट को प्रोवाइड कर सकते हैं एक बार जाके उनके घर पे। गेमिफिकेशन टेक्निक्स को हम इन्वॉल्व कर सकते हैं। और इसमें आर्टिफिशियल इंटेलिजेंस को लाते हैं, तो हम विद टेलीमेडिसिन हम पेंडेमिक में भी पेशेंट्स को फायदा दे सकते हैं। रोबोटिक ट्रीटमेंट न्यूरोलॉजिकल में लाइक गेट ट्रीटमेंट बहुत ज्यादा इफेक्टिव है रोबोटिक थेरेप्यूटिक रोबोटिक्स के साथ। ये आप लोग ने जानते भी होंगे, बहुत हद तक देखा भी होगा। ये सारी चीजों को मैं सम अप करके एक साथ आपको फाइनली बोलना चाहता हूँ फिर अगेन कि हम आर्टिफिशियल इंटेलिजेंस, वर्चुअल रियलिटी, ऑगमेंटेड रियलिटी, टेक्नोलॉजी बेस्ड रिहैबिलिटेशन, पोस्चरल रिस्टोरेशन, इन एडवांस को और ला सकते हैं ताकि हम अपने ट्रीटमेंट प्रोटोकॉल को और बेस्ट टू बेस्ट बना सकते हैं, अपने स्ट्रेस को लीस्ट कर सकते हैं, ट्रैफिक सिस्टम को रिड्यूस कर सकते हैं, पेशेंट की क्लिनिक पे भीड़ को कम कर सकते हैं, पैंडेमिक में भी काम कर सकते हैं, टेलीमेडिसिन की तरह से हम दूर बैठ के पेशेंट को ट्रीट कर सकते हैं, एक साथ कई पेशेंट को ट्रीट कर सकते हैं। बहुत सारे बेनिफिट्स हैं और बहुत सारी, इन सब पे अगर आप लोग को मैंने आज कुछ नाम बताए हैं और विजन दिया है, अगर आप लोग इस पे और वर्क करते हैं, मैं कर रहा हूँ, मैं कर भी रहा हूँ इन फ्यूचर, और आप लोग भी कर सकते हैं, तो आप लोग डेफिनेटली करिए। और हम लोग टेक्नोलॉजी बेस्ड फिजियोथेरेपी को टाइम टू टाइम इंट्रोड्यूस करें विद सो मच एडवांसमेंट। I want to thankful to this upcon and Physio nexgen for giving me this opportunity to express my views among all of my listeners. Thank you again to the team, and thank you again to all of you to listening me. Namaskar, and now I am signing off with my lecture. Thank you very much.
Hello everyone, moving towards our next lecture that is given by Dr. Dharam Pandey sir. He's HOD in BLK Hospital, Delhi, and Director in Spark Healthcare Services. He is going to explain about the stroke rehabilitation, what the role a physio can play in managing the stroke, and what are the advanced techniques that are using in the rehabilitation protocol.
How the stroke recovery takes place, what are the rehabilitation tools, particularly focusing on technological resources available to us and with us, and its impact on rehabilitation. When we talk about a stroke, what does a stroke results in? So when somebody suffers stroke, actually it causes functional loss, right? It causes functional loss. And then when we talk about function, what function is? Function is set of series of sequence of movements, right? So when we do certain sequencing of movements, like in this picture, you can see that a girl is jumping in a hurdle. So that we can consider as a task or a function, jumping function, right? And but to complete this function, to achieve this function, to complete this task, there is a series of a sequence of movements. Like you can see, something movement is occurring at hip joint, something movement occurring at knee joint, ankle joint, everybody, even at the trunk and head and the shoulder. So that's what I want to emphasize here, that the function is the result of series of movements. It is not alone something one muscle or two muscles can perform function. Okay, and when there is abnormalities of in these movements, then there is a functional loss, right? And to achieve a normal movement function movement sequence, we need to have a very effective biomechanical sequencing, how the joints, how the joint is moving and what range it is moving. There has to be very optimal soft tissue interaction between the muscles and between muscle and bone and other soft tissue and fascia and other soft tissue. And definitely to execute and these things, we need to have a very effective motor program. So we should have an effective biomechanical sequencing. We should have an effective motor programming. We should have an effective optimal soft tissue interaction. Then only a normal movement can be executed. Right. So before we discuss what the tools available to us, let us have an insight on how brain recover after injury of any injury, particularly after a stroke. So there are two types of recovery, I would say here. Is one neurological recovery and another one is functional recovery. So what do we mean by neurological recovery? Neurological recovery is something which is also, you can say, it is a spontaneous recovery. It is depends on intrinsic factors and how your brain, how your internal tissues are behaving as a result of your neurological insult. Like for example, you can see in this picture, there is an infarct, there is a middle cerebral artery stroke, where is ischemic stroke, there is a dead tissue. Because of ischemia, there is a sum of tissues and neurons have been died. But at the same time, there is some surrounding tissues are swollen, and there is a penumbra is formed. So with the effect of pharmacological agents and spontaneous process, this penumbra starts shrinking, and the reduction of this penumbra result in spontaneous recovery. Like somebody has suffered a stroke, immediately after a stroke, there is some spontaneous recovery takes place. So that's what I mean here is spontaneous recovery or neurological recovery. So the reduction in penumbral size, reduction in edema, these all contribute to neurological recovery, right? But the most important thing, what we should focus and understand better is the functional recovery. And functional recovery is defined as improvement in mobility, activity of daily living, and it is long been known and evident that the rehabilitation has a very greater impact on the functional recovery. So this is what we wanted to talk, that the functional recovery, the function, when the function is lost due to a stroke, there is abnormalities in movement, and as a result of the rehabilitation process, how effective it is, when we try to achieve the function, we need to restore the normal movement sequence in a more and more normal way, right? And that is only happens because of something called CNS reorganization. That's the process is CNS reorganization, which is influenced by a rehabilitation process. And then the key factor is neuroplasticity, something called phenomena called neuroplasticity or neural plasticity, brain plasticity phenomenon. So now you will be wondering that what this neuroplasticity is. So we can till now we can understand that the neuroplasticity is influenced by rehabilitation process, and neuroplasticity is the very key factor for restoring the function back, reorganization of CNS. And when the CNS is reorganized, then definitely there will be functional restoration or normal sequencing of movement we can achieve, right? So what is neuroplasticity? What is brain reorganization? How it gets reorganized? How neural network reorganization takes place? So to understand that, let me explain you little more. So neuroplasticity is a potential property of brain. It is a potential of brain, I would say, to react and adopt changes based on outside or inside input, right? We can say that it is in a flexible property. It is in a not fixed property. It is a flexible property as per experience, how we are getting from experiences every day. Our brain get reorganization, and it is a cortical plasticity. It is capability of cerebral cortex to alter its organization, its functional organization. I am not saying that the structure will be changed, but the functional organization, neural networking, uh, can be altered as a result of experiences. And what do we mean by experience here is how we are looking at something, how I'm moving ahead, how I'm thinking, how I'm looking at something. What are there are a lot of things to understand behind this neuroplasticity. To make you understand in a better way, you can understand with this animation, you know that there are two neuronal cells, how they connect. I will not go in that detail, but definitely the, this video, if you can see that the neural network, what we say neural network is, it is not in the way that we understand that it is fixed. It is not at all fixed. Rather, it is something looks like, if you take a 3D image, it looks like this. It is something like how our roads in our society and other places are. Like, it is a multi-directional. It is not that the fixed direction is followed when your neuronal information travels from one to one place. So remember that it is the message here. What I want to give is, remember that the brain neural network map is not fixed hardwired. It is not fixed hardwired means that it has ability that it can alter, it can change itself, right? So plasticity means to form something new. Plastico, it is derived from the word plastico. That means there is a potential of brain that it can change by practice, experience. Like, for example, we don't know how to play piano, and there is no neural network to guide the motor behavior of my fingers or hand in my brain. But with the practice, there is a neural network get created in my brain, and soon I just think of playing piano, my fingers start moving simultaneously without thinking where the sa, ni, dha, pa, or whatever the Western keywords are there. Because with the thinking itself, that finger is getting in a signal from your neural network that this finger has to be perfect, right? So that's what's the magic of neuroplasticity, right? Now here, you can see, just have an even better example. Every day from your home, you reach your destination, like your clinic, your hospital, or wherever you work for, right? So you have a certain fixed path you go with that route to reach home by your car, your bike, your motorcycle, your whatever means of travel you go for, right? But sometimes you feel that there is a huge traffic jam, right? So when there is a traffic jam, so definitely you will not be able to reach your destination as you used to be. There is a block, you cannot go further, right? So what will you do? You will start looking for something alternate pathway, and this is what the magic of neuroplasticity, that when we keep giving command to your patient, your brain, that you need to perform certain tasks, something that, and but there is that information is not reaching to that periphery. That means it is not being executed, but there is a feedback that it is not getting achieved. Then definitely the brain will restart its organization. It will try to reorganize, and the result will be that there will be certain neural network will be formed. This is the plastic the reorganization of your brain. Okay, and that happens because of axonal sprouting. It happens because of synaptic strengthening. It happens because of some of activate weak pathway. There are a lot of pathways which are not active. Yeah, they exist, but they're not active. So by repetition of tasks, by specific training, targeted training, and the task-oriented, goal-directed training, definitely we can reactivate, or maybe not reactivate the word, actually activate those weak pathways to have an efficient motor learning, right? So it can be negative or positive. Like for example, it is not right word to say negative plasticity, but definitely it's negative. It can go in negative side. Like for example, this is what we like. For example, if somebody has a stroke and they have certain adaptive behavior, like they find some way to do certain tasks. Okay, but that is not normal way to do the task, right? So in that way, that the negative adaptability goes on, and sometimes the people not learn non-use. That is also a form of negativity. We can say it is a negative learning. I can say, right? So when we talk neuroplasticity, two things you need to remember always, that there is something called how no, I'm talking about the process of neuroplasticity, how this process happens, right? So there is one thing called potentiation, and second is depression, right? So these two words you have to remember when we think about neuroplasticity process, right? Potentiation itself means that something you are trying to make it more potent. Like, so just imagine the structure of synapses, where there's a presynaptic membrane and there is a postsynaptic membrane, and what happens in these two synapses in between, that there's impulses coming. When the impulses coming reaches at presynaptic membrane, there is some chemical activities, and with those activities that responses goes to postsynaptic membrane, and it's a further travel from one cell to another cell, and in that way it propagates further, right? Okay, see, so when there is a lot of firing here, there is a lot of firing at the synaptic membrane, there will be a lot of activity between the synaptic membrane, within the synaptic membrane, and that is causing uh, the increase in response across synaptic membrane, and this is how it is potentiating. So what the result of this potentiation is, there the synapse become more strengthened, and when synapse become more strengthened, what will happen? There'll be a lot of sprouting of the postsynaptic axon, and this synapse become more and more stronger, right? So that's the example of potentiation of phenomena. But there is a depression phenomenon. When these impulses of presynaptic membranes are less activated, less of firing, then what will happen? That the chemical exchange will also be less. There are a lot of chemicals which are involved in that. I'm not going to talk in a lot of much detail about that at this lecture, but definitely there are a lot of things involved there. So it results that the response is less at postsynaptic membrane, and that's called synaptic inhibition. So that synapse will get inhibited, and result is even the existing neurons will be degenerated, or it will become less activated. Okay, so that's called synaptic pruning, right? So two words: potentiation. When there is a potentiation occurs, there will be synapses will become strengthened, and there will be synaptic sprouting, and that in that way the neural pathway will form. Whereas when there is a depression occur, there will be synaptic inhibition at synaptic membranes, and that will result in weakening of uh, or deactivated activation of existing neurons, and that will cause synaptic pruning, right? So synaptic strengthening and synaptic pruning. This is one example in this video. You can see that how it is a curative model. It is not an exact model of neurons, but definitely this animation will make you understand that how this synaptic information get traveled from one neurons to another, and when there is a neurons which are used, when the synaptic connections are more fired, they become stronger, even stronger, and when those neuronal pathways are not used, they become inhibited, and that's what the synaptic pruning is, right? So that's about neuroplasticity. Now coming on to the motor recovery after a stroke. What are the resources available to us, right? So there are a lot of resources available to us, like in form of NDT, virtual reality, PNF, CIMT, FES, biofeedback. There are a lot of tools available with us for gaining motor recovery after a stroke. But the principle and practice of difference of all these techniques, or you can say that these all technologies, right? But the ultimate goal remains same for all these therapeutics approach, or we say that a technological driven therapies. All the goals is only to promote an effective motor learning. How we can teach patients the new skill which have been normal before, and it got impaired because of as a result of neurological insult. So that's the ultimate aim of any therapy what we do. Thus optimal recovery. When we have that goal towards our therapy or rehabilitation, then we are going to restore the function, right? So most of papers now they suggest that the task-oriented movement training is best for functional restores, and you will find a lot of paper which are based in task-oriented training, task mediated. What is a task-oriented training? That means that we need to understand. So task-specific training may be defined as a systematic process of repetition of practice of a functional task. Like for example, if I'm able to, I'm training my patient with a dumbbell or something kind of that, and the patient get good strength in muscle, or maybe he's able to do, that doesn't mean that he'll be able to hold something in hand. He'll be able to do some functional task like drinking water, holding glass and water, or doing anything, any functional. What I mean to say here is it is not necessary that if I'm aiming to do certain heavy holding something, or I have good strength, that doesn't mean I'm able to perform the task oriented. This is why that task specific training has an impact on brain reorganization, that everything we make it in a form of some task, like for example holding, reaching, grasping, something kind of that for our hand. And if you talk about lower extremity, then definitely we can give more emphasis on walking, sit to stand, stair climbing, ascending, descending. All these things that comes in the functional task. That means there has to be functional task, means that it has an objective and objectivity in our daily living, right? So ADLI you can see. Now, this task-specific training can be performed with or without technological assistance, right? So what are these technological and without technology things are available to us? Like for example, in this, just look at these example of just 2 minutes. Right. So in this video, you can just see that the patient is being trained for active balance control training on some motion sensor. The patient is stand and actively making its weight shifting from one side to other side, and And this visual feedback, like this patient, you can see that he is just putting more weight on one side, right, one extremity, and we have been commanding that to transfer weight actively to other sides. So in that way, the brain can learn what the optimal weight distribution has to be. This is the one example of some technology for how we can do. And in this, there is another form, that a visual feedback assisted upper extremity training, right? So in this video, you can see that there's a target and some active device being given, which has some motor sensor, and the person can mm, achieve certain task uh, while looking at back, some visual feedback. In that way, that is also he's performing some task. Another example here is, it is a form example of bilateral training. There is something like some playing of game or something kind of that. So his task is to catch something which is moving, some birds or some kind of that, and the screen, and he is moving both the hands to achieve that task. Okay, so this is the bilateral, and the earlier one was unilateral training. Right, in that way, this is the example for lower extremity. This is a manual partial body weight supported gait training, where the patient is being made to walk on a treadmill with less, more security, by just harnessing them, and with a minimal effort, because the gravity is lesser. We do in this, that we reduce the weight by harnessing the patient, and once the patient is more confident and able to perform a control muscle, gradually we increase the load on the muscle. Right here, another example for training the shoulder or scapular stabilizer for upper extremity, EMG biofeedback guided task training, that the task is to control the shoulder muscles, and specifically there are two electrodes placed on some other muscles, and two at other muscles, there the patient is being asked to control the overactivity of overactive muscles, and start contracting the other muscles which are not activated. Okay, in that way, not only in sports and other, but in neurological rehabilitation also, we can use these kind of techniques, right? Here, another task is to keep yourself under those trampoline when there is a sensor. The patient is stand on sensor, and by moving and shifting weight, he can control his center in on that moving trampolines. In that way, it is a dynamic voluntary control training with the motor sensor. That's another example of technology assisted task specific training. The same way, task oriented, there are these were some, and there's some robotic training also. There's earlier, just as earlier I just explained about the partial body weight support. There we need to, a manpower is used to move the leg, where here it is driven by robotic kind of things. So robotic gait trainer. There are virtual reality where we give a certain task, and patient and stroke survivor can perform certain tasks which mimics the virtual environment, and it gives more motivation, it gives more visual feedback, so they can perform. Then another form is functional electrical stimulation. It is not truly this one, but earlier it used to be used for as an electronic processes, but definitely later on we explored that, and now it is being evident that we can train it, we can use it for a functional training also. Like for example, if somebody has a foot drop and they're weak dorsiflexors and they don't have any ability to dorsiflex, but the same times to improve the gait, we can start with FES, and so this is the example, a motion sensor plate, how we can make the patient stand on that, and that senses things and make people more engaged in therapy, and engaging patients in the therapy itself, and use advantage to make them rehab, right? Advantage with technology assisted training are to make it's a more accurate. Uh, the progressive monitoring can be done, like it becomes quantitative, that today where I was, and tomorrow or day after tomorrow or maybe a week or month later, I have a quantitative data that I can monitor that this patient progress was and so much. So in that case, it is an advantage. And as far as accuracy definitely, it is a fixed thing that the accuracy can be achieved very well. Repetitions, like for example, very interesting article I was reading where, and you can find it on the PubMed and the data bank, that it says that the repetitions, if you make a manual walking with the patients and versus robotic walking, can you imagine how many repetitions a patient can do, or a therapist assisted treatment can be done, but where the repetition is given by robots, it's a really high, and in that way, definitely it becomes more effective. Okay, real-time feedback, that's again very important thing. Better compliance to therapy, because the patient has a very collaborative and very um, good feedback they give. So the compliance to therapy, motivation to patient is really very good. So in that case, the task oriented training for stroke rehabilitation has a greater advantage. And definitely wherever we have chance, so we can go ahead with these type of technology. But definitely in rural areas, and has a lot of limitation as well, because the patients has these technologies are not available everywhere. But definitely we need to work upon to accommodate these technology, yes. But if you don't have, yes, at least task specific training has to be performed for stroke patients. So take home is to the task specific training, and we must focus for stroke rehabilitation. So thank you so much for listening patiently this lecture, although it was not an interactive session. So I have justified your time listening to this video, and further, if we have, definitely we will interact one by one. Thank you so much.
Thank you so much, sir, for explaining the things. Now, moving towards the next lecture that is given by the Dr. Vinod Kaushik. Uh, he is the Vice President in IAP Haryana. He is going to explain about the understanding and the concepts about the chronic pain.
Hello, my dear friends. Myself, Dr. Vinod Kaushik, practicing in Faridabad since 19 years. First of all, I will just congratulate to the organizing team of upcon, Physio, nexgen. They have organized it very well. I just wish them best wishes for this conference. And today the topic of my lecture is chronic pain. As I am a clinician, and I will directly go to the clinical aspect of the chronic pain. We have to face all the time maximum patients with the chronic pain, means the pain which persists more than 3 weeks, or I can say 1 month. We are having the patients who are having the pain since 5 months, 6 months, 1 year, 2 years, very prolonged time. Now we have to analyze what's the reason behind those chronic pain and what this chronic pain is. Is it only the pathology? Is it only the injury which creates the pain? Because of that the patient is suffering with the pain, or the other reasons are there? For that we have to understand the chronic pain. A lot of factors are there in which the emotional stress is also related to the chronic pain, anxiety, the stress which which increase the pain threshold level. I will just firstly go ahead for the two thresholds are there. We know it's very well. One is the pain threshold, and then if somebody bent this finger up to that level that it get injured, the ligaments get tear or it get fractured, that is the injury threshold. Always the movement happen in between the pain threshold and injury threshold, that we have to balance that. But that pain threshold becomes very low if all other factors, the stress is there, anxiety is there. How I can say the anxiety factors? With few factors it will be clear to you. Like if somebody has underwent the MRI or X-ray, as always we are telling, go ahead initially for the MRI. In that, the mild to moderate changes of the spine, diffuse or mild to moderate disc bulge, spurs, arthritis changes, these are very common changes. With that, a lot of times the pain is not related to that, the chronic pain is not related. That means that MRI and X-ray will increase the anxiety of the patient and their pain increases because the fear happened in their brain. In the same way, a lot of other factors are there which can increase the pain, as emotional stress, social stress, financially stress. If somebody is not on the job, like during this COVID, the pandemic time, a lot of people has to lose a job, and a lot of financial issues happened with them. As we started the clinic after 2 months, a lot of patients come to us with the same chronic pain. Earlier they were not having any pain. Same MRI was there, but still the pain aggravated. The reason was the stress level. That means assessment of the patient is very much crucial to diagnose the chronic pain. How this pain increases is the pain is in the head. Firstly, I will go ahead with the one topic. Yes, of course. The pain is in head because the brain is there in the head, and always the pain is interpreted in the brain. As we know, when we touch anything or when the pain receptors come to our skin, area of a muscle, then it goes to that nerves, then spinal cord, then brain, then it comes to back, then we feel the pain. This is the way how we felt the pain, but nowadays it becomes outdated, I can say, because a lot of other factors are there which we have to notice. If we are able to diagnose those factors, then we will be able to treat the patient very well. His prognosis or her prognosis will be very much better if we are able to see the changes, see the other factors of the stress or anxiety. Once that recovery happened, all the tissues, the damaged tissues has been healed up, still the patient is feeling pain or sharp pain is there. What's the reason behind that? The reason behind that is sensitized nervous system. Maybe a lot of physios have heard about that. Sensitized nervous system, what does it mean? The pain threshold becomes very much at that very low level, and the gap in between the pain threshold and the injury threshold is increased. This has been increased with the anxiety. As I said to you, if somebody has taken a lot of type of medication, still he is not getting relief, this is also anxiety factor. I can just give you one example. With a clinical example, it will be clear to you. But I want to tell you how you have to see the pain threshold. One lady, she was nurse, divorcee nurse, and since 2 years she was facing the pain, and it was very sharp pain. It was not cured. She just requested to his boss, director, to shift his duty from the ICU, but the boss was not ready, and then she has to leave the job since 1 year, and now she was not getting any salary. But the main problem was that she was not getting relief after taking a lot of type of treatment. When we consulted her, the thing is that a lot of other factors are there for her pain. What those factors are there? One factor was divorced, means she was in a emotional trauma, emotional stress. Second, loneliness is there. Third, because she was not doing the job, that's why the financial crises are there. Third, all the investigations she has undergone, but the changes are not there. All the tests are normal. That's why it again increases her anxiety. There was a problem she is facing. Why nothing is why she is not getting relief? These all factors is increasing her anxiety level. Because of that, you all knew that adrenaline and cortisol, the stress hormone releases, and when the stress hormone releases, with that always the sensitization, hypersensitivity of the nervous system increases. That will increase the pain, that will increase the chronic pain. I'm not telling all other factors we have to exclude, but if all other things are normal, still the patient is having pain. I have observed that in case of near about 70 to 80% of cases of low backache and cervical pain, of chronic pain, the reason is sensitized nervous system. Now, how we have to treat that? Because it's not a one day treatment in a chronic pain in a sensitized nervous system. It's a very gradual process. Slowly, we have to remove all those factors which are creating the anxiety. If those factors will be released, then the patient itself become healthier. Like in that case, we have just consulted, we have just counseled their boss, and then the boss become agree to shift her duties to a normal ward. In that the stress was not there. Then her job started. Then she has started taking the treatment. What happened with that? Anxiety becomes lower because what she was expecting, that has been done. Second thing, this is clear that she now getting the salary. That's why that financial stress has been relieved. These all things we have to take care about in clinical practice. What the chronic pain is, how we can treat it. We have to listen to the patient carefully. Other factors are there. As I said to you, pain in the head. And second thing I can say with you that we have to notice the 3 points. Whenever the patient come to you with a chronic pain, just note down 3 points. Firstly, the 3 points. What are the anxiety factors with which their pain increases? And other 3 factors are there. What are the 3 activities with which the patient feel relaxed, the patient feel joyful? Because whenever any activity we just started for the patient in which the patient feel happy, then endorphins hormone release. With that, hypersensitivity always decreases. With that, the pain threshold will become low. The patient will be cured as early as possible with those techniques. These are the things which I want to tell you today to assess about the chronic pain. I will just go ahead with another example, like when the baker's hand story is very much famous, which I told earlier also in my lectures. One of the bakers was there. His hand crushed very badly during working in the bakery, and after all the efforts, it was not possible to save his hand, and his hand was amputated. But the problem was that after the proper healing of after 6 months to 8 months, still he was facing the pain, and the same tendency of the pain was there. it was so much sharp as he got at the time of injury. And one more different thing is that only on a Sunday morning he felt the same pain. When he went to many doctors and the physiotherapist, but initially it was not diagnosed. Then one physiotherapist just went to his home. Then what happened on a Sunday? They just realized his neighbor was baking this fresh cakes and that the breads, and the smell of that, the fragrance of that baking is coming to his house. That's why with the smell his pain aggravated so much he can feel the same tendency of the pain. With this, it is clear to you that with the smell even the pain could be at the same tendency. That means the pain is always real. One thing I want to tell you, if somebody patient is coming to you and you just tell him or her it's a pain, psychologically nothing is there. No. Pain is always real. We have to treat that pain, and the pain will be resolved when the patient will say himself that he is not having pain. Patient will tell about their recovery. We are not able to tell because the patient has to feel the pain. That means we are completely dependent on the patient response, how much pain is relieved in the case of chronic pain. Now, as I told you, emotions and the pain, there is a direct relation in both that. And I just told you about the pain threshold also and the injury threshold. Now, in a chronic pain, how you will be able to treat that? It's a very gradual process. As I told initially, in case of burnt hand, if one patient is there and she is feeling pain after the complete recovery, even blowing of the air on her hand, that means, is it possible? With the blowing, the pain can happen. Physically, it's not possible. But as I said to you, pain is real. Surely the pain, we have to resolve that pain. How we have to treat? All the tissues have been healed up. Still the pain persists. For recovery of that pain, what we have to do? Firstly, light touching of the hand. You can say in a 1 hour once. Then after 2-3 days, 2-3 times in a 1 hour. After 1 week, 5 times. After every each 10 minutes, he can gently touch the hand. Gradually, we have to proceed. Like in that, firstly, we can tell the patient to dip her hand in that floor, and after that, we can go ahead up to the rice. Then, more harsh objects, we can go ahead with that. Hypersensitivity or sensitized nervous system couldn't be cured within a 1 day. As we know, a lot of techniques are there in physiotherapy nowadays. We can cure acute problems within 1 or 2 sittings also. That's really good. But in case of chronic pain, in case of if we have find it out, other injuries are not there, other problems are not there, everything is fit and fine, still the patient is having pain, still the pain is there. I can say in case of sensitized nervous system, then it's a gradual process. We have to counsel the patient the same way. The counseling should be there. It will take time. It will go away gradually. Within 1 or 2 sittings, it couldn't be cured. And desensitizations always happen with time, with the gradual consent. In the case of, we can say, burnt hand, within a 2-3 months, if the proper techniques and proper will go ahead, then it can be cured. In the same way, I'm just talking about all the patients. As I'm a clinician, as a ultrasonic therapy we are giving, I find it out that ultrasonic therapy is very good treatment. Why? The effects of the ultrasonic is other part, but the main part of the treatment, according to me, at that time is that we are getting 7 minutes with the patient. At that time, we can discuss with the patient, we can do counseling with the patient, we can do her counseling, and we can analyze other factors of anxiety at the same time. That means with ultrasonic therapy or any therapy in which you are in contact with the patient regularly, daily in a patient, so that you will be able to analyze the anxiety factors. I just want to tell you about the chronic pain. Always, in maximum cases, a lot of anxieties are there, and you have noticed this. Patients came to you, they just told, we are having pain since 7 years, 8 years, 5 years, 6 months. How is it possible? Could you think, is it possible? Cold, cough, what happened in that? It can reoccur again. But never the patient complained to the doctor that cold again come, it's since 7 years. No. The same thing we have to tell to the patient, that back pain or cervical pain, it can also reoccur if we will not take care about our spine, if we not take care about our exercises. If we told some patient, the patient has been cured with the chronic pain, and in future he has to continue with his exercises, he has to take care about his postures for the long term, for the lifelong, I can say. What's the problem? Patient has to do exercise regularly. Still, if by chance sudden jerk happens, sudden load comes to the spine, again the pain can reoccur. But at the same time, with the treatment of physiotherapy, it will be cured. That means pain, cervical, back pain, muscular pain, which I am talking the chronic pain, it can be resolved out with the proper counseling, proper relief of the anxiety factors, to encourage the patient in a positive activities, to encourage the in a physical activities. As we know, anytime we are doing any physical efforts, physical activity, any game, any fun filled activity, endorphins, the happy hormones released from the body, and those hormones are very much beneficial to relieve the chronic pain. In this way, we have to analyze the patients. I will give you one example more as how the patient can predict you. As I told one of my paralytic patient, he recovered, his hands were normal. I just said to, because the age of the patient was near about 75, I just said to him, you have to walk with the walker. He has to walk with the walker. After 15 days, he came to me.
Next lecture is given by Dr. Amit Bhura on the oromotor dysfunction and its management in children, how the oromotor conditions is managed in the small children who are suffering with cerebral palsy.
Hello everyone. Myself, Dr. Amit, I am a pediatric physiotherapist working in Raipur, Chhattisgarh, Little Seeds. First of all, thanks to upcon team to inviting me on this platform to discuss with you all. So, as I am a pediatric physiotherapist dealing with so many cases, but today topic for discussion is about oromotor dysfunction. And in oromotor dysfunction, especially in children with cerebral palsy, the common problems which everyone is who is treating the kids with cerebral palsy they are facing, it's about the problem of drooling, it's about the problem with speech production, the problem of feeding, the biting, the chewing problem, and definitely the kids who are they have sensory developmental issues also. Although the clinically it's difficult to understand whether it's only a pure motor problem or a sensory based problem, but definitely the kids with cerebral palsy, they have both the component. So today topic, it's more I'm more concerning about the treatment strategies, the technique which we can use, because it's a huge topic to discuss in a limited time. It's very difficult for me also. There are lots of things which we have to discuss, but in limited time, I really want to give you some treatment strategies which you can use easily for any child who is having some oromotor dysfunction, like the drooling problem or maybe the feeding developmental issues. So the common problem, as I said, it's the drooling. Drooling is very common in children with cerebral palsy, but most of the time the drooling issues is actually they can't swallow it properly. So the swallowing is very common, and even the poor posture. The first thing and the foremost thing as a physio for me, it's about the position. The child position is very important to make them correct in terms of their sitting, maybe on chair, maybe on wheelchair, because the alignment and the component which is important for swallowing, like maybe the head position, definitely that is important. The first and foremost thing is about the position. And Sometimes the drooling, it's maybe because of jaw weakness, the neck positions, the poor tongue retraction, because whenever we swallow something like, so it's required the tongue retraction. Most of the kids with the quadriplegic spasticity, they having most of the time something like that, because they can't close it, they can't feel it. So the tongue retraction is also a problem in children with cerebral palsy. Also the lip and jaw weakness, they are like oral breather, they are using their oral cavity for as a primary part for the respiration. So they are most of the time like, so the lip closing, which is also an important part for swallowing, it's also affected. So we have to be look for each and every component which is important, and where is the problem exactly. So the assessment is also important, and yes, before starting any kind of technique which I'm going to teach you, the important part is definitely it's about the position. Most of the time we have to understand that the position is very important before starting the technique. The sitting, the proper sitting, the support, the neck collar, and maybe sometime we required if a child is severely involved, with maximum support, and then we start the technique. Okay, so today the first technique to discuss about, it's about the brushing technique. In most of the cases, we are using some kind of vibrating brushes that called Z vibe. Sometimes we are using finger brushes, which is easily available on any kind of child product shops, and some kind we are using toothy because it's a disposable thing, so anyone can be used. How to start? This is the main thing which we have to understand. Always start from the outside of the oral cavity. So we have to tap 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 tap. Even we have to tap 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 tap. That's kind of tapping. Whatever the brush is available with you, maybe the toothy, maybe the Z vibe, or maybe the other vibrating brush. I'm talking about the therapeutic brushes. I'm not talking about the general brushes which we are using every day. No, we are not talking about this thing. So first you have to use and tap it all around. Then you have to go inside, and inside it's some kind of upper half quadrant, upper quadrant, lower quadrant. So we have to start from angle toward the middle, angle to midline, angle to midline. So it is angle to midline, and we have to rub it around 5 to 6 times, and then same thing the upper half. It is something same thing we have to do it downside also, the lower half quadrant, and then the opposite side. So this is like 1, 2, 3, and 4. So we have to cover all around the lip structure. Then we have to go toward the cheek part, the inner part of cheek. So something like, so it is just formation kind of C, a C movement, a C movement. So it is 1, 2, 3, 4, 5. So this is the second movement. The third movement, it's on the tongue. So tongue over the margin, that is just kind of swap movement to come out. So it is something like, don't ask the child to bring your tongue out. No, you have to go in, and then just to show you I'm doing this. So it is just swept movement, both the side, both the margins of the tongue, and then over the tongue, and then over the tongue it is the rolling of this. Do not press and roll, move the tongue. You have to move the equipment, the tool. So it is something like roll, 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 and do not cross more than the half of the portion of the tongue. So it is just anterior part, and come back. Even in starting, whenever you start these practice, do not start this technique like over the tongue. Just use the lip structure, the cheek, and the lateral margin of the tongue. Do not go directly over the tongue. So follow the sequence, because first we have to activate the lips, then only the child will understand that they have to close the lip, and then contraction, and then the tongue has to go back for the retraction, which is very important for the swallowing any liquid. So this brushing technique you can use with any thing which is available with you. Sometime for newborns or the young babies we are using the finger brushes, but the technique is same. Sometime we are using these kind of textured toothies, which called it's a foam things, which is sterilized one, and we can use for one patient and then dispose it after using it. And sometime we are using the Z5, which is also easily available, and then we are using it having an extra vibratory input with it, which is very useful for the kids who are very drowsy or who are not alert, to give them an extra sensation that they have this oral cavity just to chew, to swallow something. Okay, so these are the technique for the sensory input, just to give some input to the oral cavity, so that the kids can understand that's what we have to do. But finally we need some output, the motor component, the commonly which is used by therapist or by any pediatric rehab professional. It's about the blowing technique, the bubble blowing, the whistles blowing. But what is the importance, how to do it properly, that is also very important before starting this technique. So I will teach you today two things. One is about bubble blowing, and one is about horn blowing or the whistles blowing. So first we'll discuss about bubble blowing. What is the purpose, what is the goal for bubble blowing? It's not about to give a child and just blow, 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 because most of the time if the kids are like kids with cerebral palsy especially, they are using their accessory muscles and then they are blowing, which is not required for that particular training. So the goal is definitely, first, whenever we are talking about the blowing things, definitely we need to work over the abdominal muscles and the respiratory muscles. So the first goal is about the abdominal grading. The second goal, whenever we teach a child about the blowing, to blow, we require jaw stability, because if you are blowing something like that is also a kind of blowing, but that is not required presently. So we need this kind of blowing which requires jaw stability, lip rounding. And definitely whenever you are teaching a child blowing something, so it is tongue should go back, that is the tongue retraction. If the kids with especially the quadriplegic spastic CP, they are, which is not the component for blowing. So please understand, there are four things which we have to remember before starting any kind of blowing activity. One is about the abdominal gradation. You have to give them a feeling that yes, you have to use it, and then the jaw grading, and the lip rounding, and tongue retraction. So the criteria is at least they have to blow it continuously for 10 times. So if I'm giving them a blowing activities and I am asking them to blow, so you have to understand that they have to blow it with proper movements. Like what about the accessory movement? Either they can do this. Yes, it's very common. Either they can use their neck muscles, or maybe sometime they are using their shoulder muscles, so they are doing this, because it's a overfiring. And so we have to be very careful. I told you before starting my brushing technique also, that the position is foremost important. If you feel they are using any accessory movement, you have to block them and give them a proper position to blow. So sometime you have to assist them. So if you remember the component, that there are four components for blowing, definitely you can tease them. And we need continuously how many times? So it's 25 times blowing. It's important. So it's not necessary to blow one, two, three. So maybe you can make it like five sets, and continuously it should be like 25 times blowing, which is very important. And sometime we need some kind of assistance, like how to give them the input that they have to use the lips. So sometimes the therapist is sitting in front of the child and blow some bubbles and ask them to kiss the bubble, so that that busty movement, or whenever the bubble is going to burst on your lips, give an extra sensation that you have to use your lips for blowing this thing. Sometimes they don't understand that they have to make the lip round to blow. So these kind of small things, the tapping over this thing with the brush and then blow and buzz the bubbles over the child lips, it's important to give them an extra input. So it's very difficult technique to teach them, but it's very important to work over the drooling. If you understand these four components, definitely you can work for bubble blowing. So the next is for the straws. We know that we are teaching many kids for the straw drinking and to use a straw for the practice, but I think we have to understand the concept, why it is important. So definitely the goal is about, whenever we are talking about any kind of a straw, the goal is about lip rounding. So something like this, the tongue should be go back. The kids, they are doing like this, which is not required. The tongue has to go back, and the jaw stability. And definitely whenever you are teaching a child about the straw drinking, it initiates self feeding also, that you can give them a bottle or a glass to finish their feed. So that will also give them a motivation that I can do this thing for myself. So whenever you are using any kind of a straw, please remember that the mouthpiece should not go over the tongue. It should be in between the lips and hardly touching the teeth. So it should not go very too much in. So sometimes we are putting a rubber band over here, or we are making a dot with the kind of glue gun, so that they can't put the whole mouthpiece inside. Or we are having some lip blocker also, which is easily available, but it depends. If patient can afford, everything is available. If patient can't, we have to modify, because we give them many options, as there are available in many techniques. So ask them. And definitely it's depend about how many liquid they can. So there are different straw which is available. Actually this is the therapeutic straw. If it is not available, you can use two straw at a time. One is with large diameter and one is with small diameter, because that will give a different resistance. And whenever we are talking about the resistance, definitely it's a training. So from the large diameter straw toward the narrow diameter straw, it's about the more force the child has to produce for sucking any liquid from the straw. So use any two straw at a time, and give them a training. And sometimes it's very difficult for the child to understand what they have to do with the straw. So we are using some kind of straw or the bottle which is easily pressable. So whenever the kids are some kind like a fruity pack or a tetra pack, which we can press it manually. So if child is doing a correct position, then we have to press it and give them a liquid, so that they can understand, whenever I am sucking it, then only this is coming out from the bottle. So that's a part of training. There are different other techniques also, which we'll discuss some other days. So the other thing is about the chew tube program. Chew tube program, it's very important whenever we are teaching a child about the chewing and gradation of the jaw muscles. So chew tubes are available as per the color code. This is the blue one. It's available like the red, the yellow, and the blue and the green. The highest resistance is with the green one. So whenever we start the chew tube program, always understand the position is very important, and introduce the chew tube. For the young babies or the young, we have to use the yellow one. But if we are using this program for some kind of sensory kids, always we go to a little bit higher resistance, like the blue one or the green one. So how to use? place it horizontally, and then ask them to chew. And the therapist has to give little bit downward pressure with this thing and ask them to chew, and something like head should be in a midline. Either otherwise they will use this thing. They are using their other muscles to bite. So please understand this midline position is very important. And then again introduce 10 times right side, 10 times left side. So 10 times repetition is important. Again, I am saying it's a resistance, so we have to use one little bit down, like this is the blue one. So if I want to give a training to a child, definitely I will start with the yellow and then we'll go toward the blue one, or the sequence is red, yellow, blue and green. So if in between the child I can't use the first one and the last one, either it is 1 2 or 2 3 or 3 4, that kind of any two chew tubes you can use at a time, and it is 10 times and then 10 times. This is the, and usually we advise parents to use it before feeding, so that this will give the kids to extra inputs, that they have to chew the food whatever they are coming out inside the mouth. And after giving them chew tube program or some kind of sucking with the straw, we always ask them to use some kind of solid food, maybe a soya stick piece, or maybe a bread, a fried bread or something like that, and put it there and ask them to chew and give them that input that they have to chew it, chew it, chew it. So that this is the training which we give to the parents, that they can feed their child as per the need. There are so many other things, the spoon feeding, cup drinking, but as per the time, it's very difficult to teach each and everyone. But whenever the one more important thing which I feel each and everyone is using in their clinic, it's about the whistles. We are using many whistles, but we don't know how many times, how to blow it, what is the correct position. So again, I will say that if you understand the goal of this thing, definitely you understand why we are using and which component we are working for. So whenever we are talking about the whistles, definitely it's the goal is to reduce the drooling, to improve the more phonation, the abdominal gradation, lip closure and lip rounding, and lip tongue retraction. I suggest whenever you are using any kind of whistles for the kids, use two whistles, one with flat, like the flat mouthpiece, and one is with round mouthpiece, because most of the speech production is about lip closer and lip rounding, like ma, pa, ba. So it's more kind of lip closer, and whenever we are talking oh, ra, that kind of things will require more kind of lip rounding. So use any two whistles at a time. In therapeutic, there are different whistles which is available, and we have to train them. But in general, we can use keep any two whistles, like one is with flat mouthpiece and one is with round mouthpiece. And again, I'm saying it is important whenever we are using any oral technique, the position is important. To ask them to close the lips, seal the lips, and then so, and whenever it is round one, then so that is important. And this is also, they have to use it 25 times, they have to blow it 25 times. So blow it 25 times, it's very difficult. So sometimes we are using less resistance whistles, like the bath flutes or some kind of flutes which is having less resistance, and then we go further for the higher resistance whistles. I hope this lecture or this discussion will be helpful somewhere, because it's a huge discussion. There are so many techniques in children with cerebral palsy to control them, and believe me, this really works. There are many kids who are now chewing properly, who are like swallowing is improved, drooling is reduced. Within 1 month or 2 months after the therapy, you will feel lots of difference, which is noticed by parents also, and even by the speech therapist. So thanks having me today with you. I'm really happy with you, and thanks to all the team of upcon to having me, to inviting me on this platform. Thank you so much.
Hello everyone, moving towards next lecture that is given by Dr. Manad Dixit, Principal Pacific College Gorakhpur and a CC member in IAP. He is going to explain about the evidence-based practice in physiotherapy. What is the role of evidence-based practice and physiotherapy whenever we are treating the
Hi there, good morning to everyone. My wishes to UPcon Physio nexgen entire team. Special thanks to the chairperson, Deep Saxena sir and Dr. Rahul Parashar sir for giving me this opportunity. Myself, Dr. Manit Dikshit, I'm here to share my views and knowledge about the evidence-based practice. So basically, I'm here to advocate the evidence-based practice in physiotherapy. So let's see what we have. The objective of the sessions would be to explain what is evidence-based practice, what evidence-based practice is not, and how to be in evidence-based practice. So let us begin with the brainstorming question that how do you decide what physiotherapy treatment you will give to a patient for a typical low backache scenario? And how would you choose the treatment which works the best for your patient? We choose a treatment because we have read about them in the books, because we have used these before and they have worked based on our clinical experiences. So our clinical experiences does count, because the research proved that these treatments work, or because the patient tells you that the previous treatment or the previous session which he has got was really working well for him. So evidence-based practice, what this is all about, friends, this is $1 million question, because the current future or the coming future would be entirely depending upon the evidence-based practice method, whether it is physiotherapy or any other profession. So basically it contains three components. Number one is individual clinical expertise. So if you have an expertise in something that cannot be avoided or that cannot be, you know, because if you know how to give a good manipulation, that has to be considered that your skills are good in manipulation, and even if it is the second best in the hierarchy, you must go for it because you have experience and expertise in that. Second is the patient's values and expectations. So physiotherapy and all the profession are becoming consumer oriented, so the patient values and expectations are really important. Best available clinical evidence. So what are the evidences for any of the interventions which we want to give to a patient is the third component of evidence-based practice. And together these three improve the patient's outcome. At least that's what evidence-based practice. So basically, EBP promotes collection, interpretation, and application of the valid evidence, and valid is underlined word here, in the clinical decision making. So what evidence could be, guys? It could be patient reported, and previously we discussed that patient input is important. It could be clinicians observed, like if I'm giving something and I see that there is an increase in the range of motion, it has to be considered. And thirdly, it has to be research derived. So there are so many data banks or data collection centers like Pedro, SNAL. We can go there and look out for what researches, what good quality of researches has really concluded through, and we may think or decide as per those conclusions. So the conscientious, explicit, and judicious use of the current based evidence in making decision about the care of individual patient. That is what evidence-based medicine tells you. So conscientious means based on the principles. Explicit means open, clear, and unambiguous. There shouldn't be any confusion about that thing. And judicious means that you have to think over it in the last. It shouldn't be blindly followed from some written piece of paper, because we do get anatomical or geographical variation in every patient, and we have to decide things as per those also that has been accommodated in evidence-based practice nowadays. It is also very important to know what EBP is not before we can actually proceed to how to practice evidence-based practice. So asking seniors, teachers, and clinical doubts is not evidence-based practice at all. Reading outdated books, and how would you come to know that this book is outdated, is something we would discuss in coming slides. Reading outdated book is not at all evidence-based practice. Using Google for finding answers, no. Solely depending upon evidence for clinical practice without considering clinical experience or the patient's preference or expectation is not an evidence-based practice at all. And why do we need it? We need it to make clinical decision makings. Clinician often lags behind in the research and updated things, so we need it for that also. Traditional source of information, that is books, are no longer adequate. And I was previously discussing that when something has been proven clinically or been published in some sort of publication or research paper, to bring that to the books, it takes really good 5, 6, 7 years. And if you're reading some book which has been updated, or which has given you information uh, as old as 5, 6 years, sometimes it could not be the right thing to depend upon those sort of informations. It improves quality and efficiency of the healthcare management, keeps up to date lifelong learning. So it creates a tendency among you to do a continuous professional development, and it also increase the efficiency. So there is a claim कि मैंने तो एक पेशेंट में नूरानी तेल लगा दिया और उसके घुटने में आराम मिल गया. Now how would you claim that tail or that oil is not working? Because he can give you some proof also that he has applied that oil on the 10 patients and he has shown some results as per the data interpretations. So you have to go to other researchers also where they have done things differently, or where they have identified the loopholes of those researches and published a better one, claiming that no, any such oil does not work in osteoarthritis, at least not physiologically or clinically. So it improves the quality and efficiency in that way. And yes, it is a continuous professional development. Why do we need in physiotherapy? I was telling you previously that physiotherapy is a scientific approach of patient treatment, and that's what all the physiotherapists claims and be proud to be. So it justify our action and treatment. Research in therapy is very important, because how long we will continue to do our hit and trial method of the treatment, it has to be documented somewhere. Like, if for a patient I have done my hit and trial method for ages and I have concluded that no, TENS does works good for the pain relieving, so it has to be documented. And the next time when any physio goes for looking out for the options for the pain relief, he can straightway go to some research and decide that no, I would use TENS. I don't need any hit and trial method. Enough has been done in this field or in this aspect of the practice. So it standardized the treatment. It delivers the best quality of the services to the patient, easier and safer clinical decision making. As I was telling you, that hit and trial methods sometimes do not hit or do not give you the desired results. So if already that effort has been taken, you can straightway go to the documents or the papers and decide that no, I would do this, and you would save your patient from so many harms. Pedro is one of the site where you would get so many research. And why it is so popular? Because it gives the grading to all the papers in the articles. And if you just see that the countries like USA, Australia, Brazil, UK, Spain, and Germany, they are already using it in good bulk, but we use it very low, and India ranks 99 in terms of using sites like Pedro. So it just tells that how much we are lacking in case of evidence-based attitude. It is important for student also, as I'm assuming that this time my listeners, most of them are students only, to update your knowledge, which we just mentioned that sometimes it is not in your books because of the technical fault, to identify the most accurate diagnostic test and most effective interventions, to build a strong clinical reasoning based on the best available evidences, to defend the answers. Viva is a great pressure causing thing in your mind when you go through your Viva and examinations. Many often you have a long discussion and argument with examiners. So producing some papers or some good quality of articles will really defend your point. And anyway, we use internet as a source of learning nowadays, don't we? So if we are using internet, why not use it in more precise and organized manner? And that is all what evidence practice is all about. So how do we do it? So basically, there are 5 steps to follow evidence-based practice. Number one is to convert a clinical problem into the answerable clinical question. We would just discuss that in detail. Find the best evidence, literature search. Critically appraise evidence for validity, impact, and applicability. Apply results to clinical practice. Evaluate the effectiveness and efficacy. So first and foremost is to convert a clinical problem into searchable question. अब अगर आपके पास एक पेशेंट है और पेशेंट को कुछ प्रॉब्लम है, आपको उसे कोई इंटरवेंशन देना है, so there would be 4 things and we have summarized it as PICO. P stands for patient or population, I stand for intervention, C stand for comparison, and O stand for outcome. Patient could be like बच्चा है, बूढ़ा है, pregnant woman है, elderly है, so there is a geriatric problem, sports injury or whatever. उसकी एक particular population है. ये population बहुत important, I'll just tell you why. Then there is an intervention which you have decided, that is cryotherapy, US, IFT, and as per your clinical knowledge and as per your previous experiences, you would have 2 or 3 things in your mind which you can give to that patient for that particular problem. And then you will have a confusion. Ice दूं कि cryotherapy दूं? So here is the point where you need some proper guidance or consultation. And rather than taking it from your seniors or teacher, why not to practice evidence-based practice? How come? You simply decide the outcome which you were expecting in your patient, that is pain, function, ability, muscle, strength, range of motion, whatever, by giving cryotherapy or ultrasound. And then you would look out for the researches. Now, what you would do is, it could be lesser precise if you just say कि osteoarthritis में US का क्या role है, and you frame that question in that way and you look out for the articles or for the researches. But अगर आप इसको और precise बनाना चाहते हो तो आप उसमें age डाल दोगे कि after the age of 60 osteoarthritis में US का क्या रोल है, या और precise बनाना चाहते हो तो आप ये डाल दोगे कि after the age of 60 osteoarthritis में which one is the better, ice or ultrasound. So जितना ज्यादा आपका framework अच्छा होगा, solid होगा as per the PICO क्वेश्चन और आपका रिजल्ट जो आप सर्च करोगे एविडेंसेस, आर्टिकल्स, रिसर्चेस की अगर किसी ने कोई पहले से पब्लिश की हुई है तो आपको उतना ही precise आंसर मिलेगा. And of course, for these researches and articles, you can go for the many databases. Cochrane, Pedro are just recommended from my side. PubMed, Medline, Scopus, Embis, Clinal, Procust, these are all very good databases. So critically appraising the evidence is as critical as framing the question, which was PICO. So when you critically appraise an article, you again rely on those basic frame of your PICO. Like this particular evidence, suppose करिए हमने नी जॉइंट के मीडियल साइड के पेन में यूएस की एफिकेसी चेक करने की कोशिश की in comparison to eyes. Now we have to see that the article which we are relying upon, उसमें भी patient की age वही थी जो हम दिखा रहे हैं. Sometimes we can also see that जो article पे हम rely कर रहे हैं उस patient का background क्या था. कहीं वो sports player तो नहीं था, कहीं वो jogger runner तो नहीं था, और हमारा वाला patient is just a lazy day-to-day activity doing person. So there would be a difference in the outcome if the background of the patient is different, if the level of the injury or disorder is different. So we have to analyze in that sense that how reliable this article or paper could be in our case, plus how efficiently the article or the paper has been published. इसने डेटा सैम्पलिंग सही की हुई है, कोई ब्लाइंड सैम्पलिंग अच्छे से फॉलो की है कि नहीं की है, कंक्लूजन ड्रॉ करते हुए कोई मिस्टेक तो नहीं. सो वी हैव टू लुक आउट फॉर द लूप होल्स. सो दिस इज व्हाट वी डू इन critically appraising the evidence. We just cannot take any evidence out of the box and apply it in our patient. That would be a wrong method to do. And there is a hierarchy. Those who are knowing research methodology would understand this slide better. Due to lack of time, it would be difficult for me to explain all those in details. But if you know these terms, there is a hierarchy. बहुत तरह के papers होते हैं और उसमें meta analysis and systemic review. Systemic review in short में अगर बताऊं तो जो बहुत सारे articles हमारे पास होते हैं एक ही particular question और topic पे, तो उनको एक जगह इकट्ठा करके फिर हम उनका भी एक conclusion निकालते हैं. 4 आर्टिकल ने कहा कि यूएस इफेक्टिव है, 2 ने कहा यूएस इफेक्टिव नहीं है. तो ओवरऑल हमारे पास 6 आर्टिकल है जिसमें 75% हमें ये डेटा मिलता है कि यूएस इफेक्टिव है. तो इस तरीके से हम एक कंक्लूजन निकालते हैं बहुत सारे आर्टिकल्स का. दैट इज कॉल्ड सिस्टमिक रिव्यू. रैंडमाइज्ड कंट्रोल ट्रायल इज अ क्लिनिकल ट्रायल. तो ये हायरार्की है. इस हायरार्की के बेसिस पे अगर कोई, जैसे हमें एक एक्सपर्ट ओपिनियन मिलता है जो बोलता है कि टेंस पेन में इफेक्टिव नहीं है, बट देन वी गेट अ सिस्टमिक रिव्यू व्हिच से दैट नो टेंस इज इफेक्टिव इन द पेन. सो वी वुड रिलाई ऑन द सिस्टमिक रिव्यू बिकॉज इट इज हायर इन द हायरार्की. नाउ यूज द रिजल्ट ऑफ द लिटरेचर सर्च. ये जो लिटरेचर सर्च हमने किया, हम इसको सिर्फ अपने ट्रीटमेंट प्रोटोकॉल में ही इस्तेमाल नहीं कर सकते, हम कई तरीके से इस्तेमाल कर सकते हैं. Our question could be of different types. Sometime it has to be the treatment protocol only, but वहां से फ्यूचर का रिसर्च क्वेश्चन बन सकता है. Cost effectiveness of the treatment, mind you, could be a very important thing which can also be done by applying these results. अब जब हमने ये 4 स्टेप फॉलो कर लिए, तो 5th स्टेप इज टू इवैल्यूएट द इफेक्टिवनेस एंड एफिकेसी विद विच स्टेप 1 to 4 वर कैरीड आउट. कहीं हमने खुद तो मिस्टेक नहीं किया. जो लूप होल्स में बता रहा था, जो मेथड में बता रहा था, देयर शुड बी नो मिस्टेक इन दैट वे. Think a way to improve and evaluate the efficacy of the intervention on the. फिर उसके बाद हम देखते हैं कि इस मेथोडोलॉजी से जो इंटरवेंशन ने चूज किया, डिसाइड किया, उसकी क्या एफिकेसी है. सो दीज आर द स्टेप्स: आस्क, एक्वायर, अप्रेज, अप्लाई, एनालाइज एंड एडजस्ट. These are the 5 evidence. What is the optimal evidence? Now, every time you cannot really choose the best one to apply on your patient because you have so many reasons to not do so, as sometimes you are just not equipped, sometimes you preferably think that they are not the current or the latest, sometimes the best evidence is just not valid in your case, sometimes it just not be the relevant in your case. So what is the optimal evidence? It has to be best available, current and latest, valid and reliable, relevant, applicable, and cost effective. So these are the parameters on the which you would choose that which of the evidence is the optimal one in my case. So I hope by end of this session, we would be knowing that what is evidence-based practice, what it is not, why EBP is being practiced or should be practiced, and how to practice evidence-based practice. Really thank you, the entire team and the organizing members, for this opportunity to me to share my views. And friends, I must once again conclude that future is evidence-based practice and everyone should start getting inspired by this method of practice and
is pain and posture with ergonomics, a physiotherapist perspective. First of all, in this topic, we read and we learn about the pain and posture with ergonomics, how to correct the pain and posture with the ergonomics, a physiotherapist perspective. First of all, this is my brief introduction about this is the pictures I will show you. I watch show you to this is the workplace where I work in the quota. Pain at the end of the presentations, my objective is the introduction, about the ergonomics, understand basic concept of ergonomics, benefit of ergonomics, identify common work-related musculoskeletal disorders, MSD, learn strategy to decrease the MSD injury and risk, prevention and control, or introduce physiotherapy exercise. After each and every participant able to learn about this topic. The goal of my program is to reduce the work-related musculoskeletal disorders developed by workers when their job involved, to minimize injuries due to chronic physical and psychological stresses while maximizing productivity and efficiency. What are the goal of this program? When you learn about the ergonomics program, you reduce the work-related musculoskeletal disorder. Everybody know about the musculoskeletal. These are related to your muscle. These are related to your bone. These are related to your fascia. So these conditions decrease, and again we minimize the injury and chronic physical psychological stresses when we are working in any type of workstation. First we introduce about the what is history of the ergonomics, definition of the ergonomics, what is ergonomics and why ergonomics is important for our pain and posture. So first we take history. As early as 18th century, doctor noted that workers who required to maintain body position for long period of time developed a musculoskeletal problem. And last 20 year research have clearly established connection between certain job tasks and repetitive stress injury or musculoskeletal disorders. What is ergonomics defined? If we're talking about the definition, so the definition is ergonomics is the science of fitting the job to the workers. If we divide the ergonomics word into two things, ergo means work, norms means law. Again, what is ergonomics? Ergonomics means the applied science and art that seeks to fit the job to the workers through the evolution and design to work environment in relation to human characteristics and interaction in the workplace. Adjusting the workspace to best fit the employee. Where the employee is working, these are the best place of the employee. It applies to every job. If we can't say it is applied only the physiotherapy, it is applied on the orthopedics, it apply on the neurology. No, it is applied in the each and every workstation where the person is work. It is working in the eminency, it is working in the industry, it is working in the education, it is working in academic, it is working in a hospital. It is ergonomics apply every job, every type of workstation. Each employee responsibilities that they are aware of ergonomics hazards and take the step to reduce them. Each employee responsibility that they are aware about the ergonomics hazards. Why ergonomics is important? Overexertion leading cause of injury. When we doing a overexertion in our workplace and one workstation, it is causes the injury. Or when the most costly recurring persistent pain might develop in future. If you suppose that you are working in a industry and you are suffering from any injury in current situation, when we deal with we correct in ergonomics, and if you are doing something in the same manner again in your workstation, it persistent again and recurrence again in the future. So bodily reaction in another leading cause of injury in a workplace. Our body, what type of our reaction? We are sitting, we are standing, we are kneeling. These are the body reaction. And last, repetitive motion, with also within top 10 most common workplace. A repetitive motion is the we do again and again because we can't left our job. We do it is necessary for our working. So we do the job in our workstation. It is repetitive motion within the top 10 most common workplace injury. So this is again the scenario and the picture will show ergonomics today, but in the current situation, the ergonomics fitting the workers to the job. There is a bilkul. This is a I think this is a reversely reversely reaction fitting the job to the workers. There is a fit the employee, what type of workstation, what type of what tools, what type of design. It doesn't matter. We fitting the worker. Every employee, every institution, every organization need about the fitting the workers to the job. Result of, if when we fitting the job, we fit in the job, these are the we uh, we are working in a poor ergonomics design, or when we are working in a poor ergonomic design, we this may cause discomfort and fatigue of our joint, injury and accident, increase the risk of injury and accident also. It is decreased efficiency. If my working efficiency is the 6 hours, but my boss want to the work for 8 hours, so again it is a decrease the efficiency of the persons, decrease the productivity. I am giving the productivity only the 6 to 7 hours, but I am fit in the job in the 8 to 10 hours, so I decrease also my work efficiency. My work efficiency decrease the productivity and satisfaction of the client, and it is increase also the errors. Poor ergonomics design, again this is a scenario, you can see that in the diagram. There is a, if the panel discussion is there, though there is a no employees there, there is nobody interested, only the audience is there. Employees are not there because they are the absentees. Because of the poor ergonomics design, they suffering the musculoskeletal disorders. So decreased turnover, absenteeism is increases on job avoidance by the workers. So these are also the main factors about the poor ergonomics design. Again, so what do I get a start? How do I get a start? Where we I state, pick your fight, sell your service, work smarter, not harder. So what should I look for? Which place I should look? So this is the, there are three places: the tool, the task, and the workstation and environment. These are all are related to the users and operators. Who are the users? If I am doing the work, I am the users, I am the operators. So these, you think that about the ergonomics focus three things: the tools, which instrument I will use, which instrument what, which instrument where I work, which type of workstation, what type of task you do in your workstation, and what type of your workstation or environment where you work. You are work in a good temperature environment, or you are work in a bad temperature environment. Do you work in a noisy environment? These are the all are the related to your ergonomics focus. So these are the three things. Again, I reminded the tools, the task, and the workstation and environment. So the little bit anatomy is here. The common work-related musculoskeletal disorders. The muscular common problem is the neck problems, back problem, arm and hand problem, and knee and foot problem. These are the common problem. Those are related to your musculoskeletal disorders. A bit of anatomy. What are the musculoskeletal? Earlier I told you in my previous slide, MSD are the injuries and illness that affect the muscle, nerve, tendon, ligament, joint, and spinal disc. So what causes these injuries? These are the main 5 risk factor of these poor ergonomics: repetitive force, posture, environment, personal, and force. These are the 5 factors. These are increase the risk of injury and musculoskeletal disorders. Where should I look for? I look for what the constant posture, your work posture and position where I work. So you should look for these postures first. Then what should I look for? Again, reaching where, if you are working in an industry, if you are working in a factory, if you are working in a lab, you are working in a hospital. So where do you do, what type of your work? Your type of work is a reaching, your type of work is a bending, your type of work is lifting. So you should look that type of things. What should I look for? Again, you should about the forces. What type of forces? How many, how much forces you are exerted on your body. Again, you should about the forces. Again, repetition, hand intensive work, highly repetitive motion. Again, you should look for about the repetitive movements of your hands. If you are continuously working in a repetitive, well, you are suffering from the repetitive stress injury. You are suffering with the tendon injury. You are suffering with the muscle injury. Again, related to your musculoskeletal disorder, also known as MSD. What should I like for? Again, direct pressure or contact pressure. How many time or how much time in a day or how much time in a week, how much time in a month you seated on a chair, how much time you spend on a chair in your office, your workplace station. These again the risk factor of you should look for contact pressure, yeah, direct pressure. What should I again the vibration, noise, environmental? These are again you should look for about the if you are again previous slide I also told you that ergonomics is fit in the each and every type of workstation and workplace. You can't say it is apply only the hospital industry, and you can't say about it is the academic industry and you can't education. No, it is related to each and every workstation, each and every type of work. So what should I look for? You should look again the vibration, noise where you work in your workplace. Questions. There are again question, what can ergonomics do? If I look for all the things, I look for the force, I look for the posture, if I look for the repetitive motion, if I look for the force, it is for the vibration. So what can ergonomics do? Again the question arises here. So I give you a big picture about the ergonomics. Ergonomics do decrease the discomfort of your joints problem, decrease the accident and injury in your workplace, increase the accuracy rate, increase your efficiency, increase your satisfaction, or increase your job retention. If you are happy, if you are healthy, if you are not having a problem in your joint, if you are not having a problem in your muscle, if you are not having a muscle in your related to body, so you increase the accuracy rate of your workplace, you give your 100%, you give your 100% efficiency, you are 100% satisfied with your job, and you avoid job retention. So what can we do? There are the three types of the method we control. If we control these three methods, we working in a good place. We can say that we applied in a good environment. We work in a good atmosphere. We work in a good industry. So these are some changes is there. Administrative controls, work practice control, or engineering control. These are the three controls. They are decrease the musculoskeletal disorder. So first we discuss about the administrative control. Administrative control, employee rotation. We do that rotation of the employee, job task expansion. Again, physical adjustment to the workplace. We do the increase the physical adjustment to the workplace to the employees. Redesign of work methods. We again redesign according to the employee the work method. Alternative task, you can do the alternative task, and you take some frequently breaks in your workplace. If you're taking a breaks in a 1 hour, you can see the each and every conferences. You can see that. I remember that when you are going to each and every conferences, there are some speakers are coming. You are sitting on the chair in front of the dais. Everybody come, stand up, move here, move there, move up, move down. What is this? These are the breaks, because you spending the much more time in a particular position. So they are coming and saying stand up, lift, bend, side, flex, extend. What they did, if they give to breaks in a long sitting, because of the if you are sitting in a long posture, you feel fatigue, you feel discomfort. So these are the backs. Work practice control, safe and proper work techniques and process. We use the safe and proper work technique. I will show you in the next slides. Training. We give the trainings for our employee to operate the things in a good manner, operate the things in a bad manner. We give the training about the operating the system in a workplace. Physical conditioning period. We also give the time to physical conditioning for the cool down phase, warm up phase, rest phase, and breaks also. So these are the physical condition work practice control. We include all those things. We use the proper work techniques and procedure. Correct lifting. If you are using a correct lifting technique, we are safer in our side. If you are using an incorrect technique, you feel discomfort. If you are using again and again, you go for the injury. You suffering from any stress type or repetitive stress injury. Proper work techniques and procedure. We use some small tools to if you are We lift the heavy weight, so you using a cart, we use a handle, we use a tools. So we are using, if you are, because we can't left our job. This is our daily routine procedure. So we can't say that I am not doing, sir, I'm not comfort daily. No, we use it, we change our proper work technique and procedure. This is depend on the training purpose. Again, proper work techniques and procedure. Backward posture, whether your tasks are performed while sitting or standing, always maintain proper posture, angles, and avoid backward position and extreme reaches for materials. These are again the part of the proper work technique and procedures. Think of posture. This is the main concern about the posture. Every time in a week, daily, we see that daily, we see and treat that the patient, those are working in a MNCs, multinational company, they are sitting in a laptop in a 5 to 10 hours. They are suffering from upper back problem, cervical neck problem, trapezitis. These are the what this thing. These are the postural problem because they fit in the job. They are not employee fitted the job. No, their scenario will be the change. They fit in the job, not saying, not proper sitting technique, not proper banding technique. They fit in the job for 8 to 10 hours for the completing the task. Those boss are offer. जो भी बॉस ने बोला है वो टास्क वो कंप्लीट करने के लिए अपने आप को कंप्लीटली फिट कर देते हैं उस जॉब के अंदर. वो ये नहीं सोचते हैं जिस जॉब के लिए मैं ये काम कर रहा हूँ वो मेरे लिए हजार्ड है, आगे जाके प्रॉब्लमेटिक बन सकता है. बट नो, दे डोंट लुक लाइक दैट. they are doing only job. So I can say that posture check, increase stress or decrease circulation. If you are increase, these are the two pictures in there. One is the red, one is the green. If you are obtaining a proper posture and proper sitting technique, so there is no discomfort. If you are using a wrong techniques, you are not proper angles, you are not ideal position of your posture when you are sitting in the chair. So these are the high risk guide. These are the high risk, and this is a low risk. Again, my next slide will show you completely. Think of posture. So this slide also very serious condition about the, you think about your posture. Where are you working in a industry? Where are you working in your workplace? It is not related. You are working in industry. You are working in a MNC. You are working in a academician as an academician. So proper work techniques and position. Again, I focus body angles. What are the head angles? It is a less than 30-degree head from your screen side. Your shoulder should maintain the 70 to 135-degree angle. The arm at the side, elbow 70 to 135-degree. Hands positioning, hip and knee position 60 to 90-degree, hip 90 to 130, waist, leg, and feet. These are the normal posture of the. This is a picture. Will show you the body position, body angles. Proper work techniques and procedure. Again, word on repetition. Some newer research demonstrate that the repetition is significantly less of a problem versus posture. So again, these are research is showing, because repetition is the not less problem if we compare about the posture. The posture is a very posture problem is a very dramatical and very high risk problem about the long sitting posture. Again, work on contact stress. Where do you work? At your workstation. Notice where your body comes into the contact with the object. What type of object, localized pressure on your body part, which type of position you are doing a work, what type of position you take when you are working in a constant time. So these are again, it is depend on your choice. Your choice is the proper work technique and procedure. Again, engineering control. Now we are coming from the administrative control. Now we are coming from the engineering control. So these are the workstations, tools and equipment. What type of tools we using and what type of environment where do you your work. So these are the workstation. This is the diagram of your proper workstation. Shoulder positioning, your head positioning, your waist positioning, your back positioning, your elbow positioning, your hip positioning, your knee positioning, or your ankle positioning. These are the proper ideal workstation diagram. in my current slide. Laptop again. Laptop should only be used. We are daily working in a 6 to 8 hours in a laptop. What I will again I will focus about the laptop. So laptop should only be used for short period of time, if not ergonomically retrofitted. But nowadays we are using a long period of time. Retrofitting means adding a full size keyboard, external mouse, and raising the laptop to the eye level to promote neutral body positioning. Consider transporting your laptop in a roller cart or ergonomically designed bed. Again, I say one thing, one line about the laptop. In previously, we using a desktop. Now we are using a laptop. When we are using a desktop, we are sitting in a erect position because it is not a band in according to you. In one line, we can say that in previous time, desktop are rigid and person are flexible. But now we can say that laptop are flexible, the person are rigid. Agree or not? It is on you. But my side, when when you are sitting in a bed, when we're sitting in a anywhere chair, we open the laptop and start the working. We because laptop we change the angles. Nowadays there are the 100 360 degree rotator laptop are there, 180-degree laptop are there. But in previous time, the person is flexible and the desktop are rigid. But now the scenario will be the change. The person is suffering from the rigidity, stiffness in our body because the laptop is flexible. Tools, what type of tools we are using to decrease the proper technique, decrease the discomfort of our joints. So these are static anti-fatigue mats, vibration tool, anti-vibration material, anti-vibration mount, handles, external support, anti-vibration gloves. We are using this type of small tool we change in our workplace, our workstation. We can decrease the risk of the injury of the musculoskeletal disorder, and we increase the accuracy of our work. Environment, again the lightning and glare. Where you work, the lightning is a proper ventilation are there. You are not working in a full day light, you are working in a sunlight. When you need it, you on and off your light. So these are again the environmental should be proper. If you are using if you are doing a single work, you're using a task lighting. Temperature, again your temperature should be normal in your body will be good work in a which type of temperature you are working in your workplace. Noise, again we are using, if you are using in a noise place, you are again the problem of your musculoskeletal disorders. Again you every time your ear heard about the noise. These are the noise pollutions. These are every time because of there are the rays of the noise are coming in your ear. They irritate you each and every time. So because so this is your again you confirm about your environment. Vast outlines which are all told you about in my PPT. Tension and stress, ask yourself. It is your job. It is your choice. It is your choice. It is your own job. So vast dotted lines, ask yourself, you are safe or you are not safe. It is up to you. But my words, these are the things about it. There is a no-brainer. Some final words from my side. If you are not thinking about that, it's your problem. So some final words from my side. Safety in ergonomics is not just a work thing. A big picture is waiting for you. Prevent, prevent, prevent. What I do, what to do, how we decrease the problem of the MSD, how to decrease the problem of the posture, how to decrease the work of repetition, warm up and stretch before activity that are repetitive, static or prolonged. Take frequent breaks from any sustained posture every 20 to 30 minutes. Respect your pain. Position to stop painful activity. If you are suffering from any pain, respect your pain. You stop the work. And first you relax then you start your work. Recognize early sign of inflammatory process and treatment early. If you recognize your condition early phases, it will it will treat in a simple way. If you are not recognize your problem in early alarming sign, it will increase the condition. Now disease turn into the deformity. So you every time you judge your alarming sign. I first of all I cover all the body parts in our exercise parts of your when you are doing a when you are doing any type of workstation for a long period of time, you are some physiotherapy exercise I introduced you. I started from the eyes comfort exercises, blinking, yawning, and focus changes. These are the three type of exercise you're doing in a workplace also. While seated, eye palming. While seated, brace elbow on edge of the desk, let feet all forward. Cup hands over eyes and close eyes. Inhale slowly through nose and holds for 4 seconds. Continue deep breathing for 50 to 30 seconds. These are these all type those exercise I will read here, I will teach here, I will introduce here. You can do in your workplace also. It is not it is time consuming. It is for 15, just more about 10 to 15 minutes, and you also doing in your workstation. It is if you are not any time, you are busy schedule, you doing in your workstation when you are any free time. So these are continued for 15 to 30 seconds. Eye palm, eye movements. Close eye and slowly and gently move eyes up to the ceiling, then slowly down to the floor. Repeat 3 times. Close eyes and slowly and gently move eyes to the left, then slowly to the right and repeat 3 times. These are the yamming of eyes. Next stretch. Tilt ear towards shoulder. Reach up to touch top of the head with the palm to head in a tilted position. Hold for 5 to 10 seconds. Repeat 2 3 times. Come out of stretch slowly. Reverse side and repeat. Again, stay peak corner stage. If you are suffering from the postural problem in upper back, trapezitis, these are the forward head posture. These are the peak corner stretch. It is a very good exercise. Stand at a corner about a foot away from the wall with forearm and opposite the corner. One foot should be forward. Elbow should be at slightly below shoulder height. Keep abdominal tight toward arching back. Lean gently towards corner by bending the front knee until a stretch is felt in front of the chest, and hold 5 to 10 seconds. Repeat 2 3 times. Again, overhead reach. When you are sitting in an office and a chair, you can do at that same time. Take a deep breath and reach up, overhead with both arms. Hold 5 to 10 seconds. Exhale and lower slowly. Repeat 2 3 times. Shoulder pinch. Place arm behind the head, being careful not to press the head into head. Relax shoulder and squeeze shoulder blades together while keeping shoulder back and down. Hold 5 to 10 seconds and repeat 2 3 times. These all exercises you doing in your workstation. Sitting upright, straight, slowly bring shoulder up towards your ears. Hold position 5 to 10 seconds, then bring the shoulders down and hold. Repeat 2 3 times. These are the shrugging of shoulder. Chair rotation stretch. Sit in a chair and place feet flat on the floor. Reach across your body and grab the back of the chair. Pull gently to increase stretch in a mid back. Hold 5 to 10 seconds. Repeat 5 times. Repeat on either side. Arm behind back stretch. Hold hands behind back and grasp hand together. Pull shoulder blades back and down. Hold 5 seconds. Repeat 5 times. Thoracic spine extension stretch. Lie on your back. Place a firmly rolled towel under your shoulder blades across your upper back. Raise arms up as you inhale. Lower arms as you exhale. And hold a couple of seconds. Do this 5 times. Again, these are the thoracic spine extension stretch. Prop-ups and press-ups. Lie on stomach and either prop-ups on forearms, or if wrists are not compromised, compose up and throw hands. Let stomach sag and allow back to arch without using back muscles. Back muscles. If propped up on elbow, Hold 5 to 10 seconds, repeat 5 times. If on hands, press up down and slowly 10 times. There are also in sitting in a chair, you can do that exercises, foot rotation, ankle rotation we can say. While sitting upright, slowly rotate each foot from the ankle 3 times at one direction, then rotate 3 in opposite direction. These are the ankle rotation. Wrist flex and extended, we can stretch our wrist in a flex position. We can stretch our wrist in a extended position. Again, the finger massage, very gently massage, and the fingers of each hand individually move toward the nail, gently massage the space between the fingers to widen and relax. Squeeze, finger squeeze, squeeze a foam block or the edge of your desk firmly, fingers, hold for 3 seconds, relax your grip. Practice wellness at work and home. We are the take home message, exercise, nutrition, and relaxation. And last, from my side, an announce of prevention is worth a pound of cure.
Hello friends, I am Physio Yogesh Mandhyan and my topic is shoulder simplified. It is all about the shoulder complex, and as the name suggests, or it may sound that it is a complicated thing, but believe me, through Jeremy's method, it's going to be very easy today. Before starting the main topic, let me share my journey in physiotherapy with you because many of you can relate it with your journey also. When we began physiotherapy, like in mid 90s, it was kind of dinosaur era, as the whole profession was governed by massage walas and passive stretching walas, that bone setters, malish walas, and nobody knew what physiotherapy exactly is. But using change, things became better in like 2000 to next 15 years, and lot of electrotherapy era came. A number of machines like current therapies, IFTs, TENS, Faradism, Gallery, although it was there, but in this part of country, it is evident that during 2000, a paradigm shift in physiotherapy came. And nowadays, we have ended up in laser therapy, shockwave therapy, so many current therapies or electrotherapies. Then came a era during those time, like in 2005 till now, that is the era of techniques, rock stars era. So many names, so many techniques like Maitland, Mulligan, MET, that is muscle injury technique, MFR, myofascial release, McKenzie methods. Everybody is running after the techniques. So things have changed dramatically in physiotherapy in last 25 years, but there is only thing, and there will be only one thing which is evergreen, and that is exercise therapy. As Jeremy rightly says, exercise therapy is the first best treatment option for shoulder conditions. Medicines and surgery have a very little role in non-traumatic shoulder conditions. So, exercise therapy is the first best option in non-traumatic shoulder conditions. A very quick review of shoulder complex. Let's revise it, that the shoulder complex is not only glenohumeral joint, rather it consists of sternoclavicular joint, acromioclavicular joint, scapulothoracic joint, and of course glenohumeral joint, which all together moves in a very synchronized fashion to make the shoulder elevation complete. The whole complex is supported and stabilized by many ligaments and muscles around the shoulder complex. As we all know, the main The most important muscles are rotator cuff muscles for the stability of shoulder, but very less physios know that there is a rotator cable from which all the rotator cuff muscles are linked. It is clearly evident that rotator cuff muscles are social muscles. The rotator cuff tendon is not alone. It is helped by all other rotator cuff and also other muscles through this rotator cable. It's not like tendoachilles, which is a alone tendon. No other tendon or muscle is going to help it during injuries. But in rotator cuff muscles, the injury is well supported by other muscles also. Thus, it is not easy to pinpoint it that it is a supraspinatus tendinitis. Maybe other muscles are not working that well, so that supraspinatus has to take all the load, or maybe it is the tendinitis of other muscles also. Thus, in spite of working for so long, a long experienced physiotherapist also need to revise the basics every now and then. Like we need to understand that with credit, with all due respect to BD Chaurasia's sir book, that it is a wonderful book, but maybe it is not for physiotherapists because the approach of anatomy, the approach of muscle is region wise. Like the anterior part of shoulder, like the posterior part of shoulder. The chapters are like head, neck, upper limb, thorax. What happens when you go through BD Chaurasia sir book? You tend to get confused that whether latissimus dorsi is a muscle of shoulder or it is a muscle of back, because you do not find all the shoulder complex muscle in a single chapter or in a single heading. While physiotherapist is directly related to the movement science, thus it is very important to know what muscles make the shoulder complex move. A better approach to understand muscles is, especially for shoulder, that we need to classify the muscles in scapulohumeral group, axioscapular group, and axiohumeral group. That means the muscles which are originating from scapula and inserting to humerus are going to make humerus movement, while the muscles which are originating from the mid part of the body, like spine or ribs, and going into scapula, they will be the scapular mover. In this way, you will never confused, especially whenever I ask my junior or student, tell me the movement of pectoralis minor. They always tend to reply that it is the internal rotator of shoulder. Now, how come it is possible? Because P minor is not inserting in humerus. It is not going to move shoulder movement. It is a axioscapular muscle. It is inserting in scapula. It is not like P major. It is P minor. So you need to understand which muscle is inserting on what bone. It is going to move it in the bone into the direction towards its origin. So let me
Wow,
put
what a nice
my
lecture.
thing
Of
or
eyes,
the
Social
Chinese
muscles.
philosophy
nutrition and
in
relaxation.
a story way
And last,
Paradism.
to get the real
The whole
clinical
complex
scenario
is
on
to
the virtual
revise the
platform.
basics every now and then.
Like
It is
here,
a
you can easily
ac-
appreciate in
now
this
all the
slide that there are
symptoms are
three
same. Like
physiotherapists,
all three patients are
Shailendra,
45 years,
Nancy, and
40 to 40.
Aklim. All three are working in their respective clinics. Shailendra is attached with a private hospital, then Nancy is running her own clinic, and Dr. Aklim, is in charge at a super specialty hospital. And all three gets their shoulder patients. Number one is Mr. Amar Mishra, being treated by Shailendra ji. Number two is Dhirendra Sen, treated by Nancy Sharma at her own clinic. And number three is Mr. Rahul Verma, who is receiving physiotherapy at a multi-specialty hospital. Now all the symptoms are same. Like all three patients are 45 years, 40 to 45 years male. All the patients are presenting pain, inability to raise arm overhead, nocturnal pain is there, onset 1 month, no history of trauma, but the clinical features are same. Now here, a well-versed physiotherapist is supposed to apply clinical skills to diagnose what is the source of symptom in my patient, while clinical features are same. So you need to know the source of symptom, which is wonderfully explained by Sir James Henry Cyriax, and it is called Cyriax method, that is STTT, selective tissue tension testing. Here
Wow, what a
we
nice
ask patient to
lecture. And
perform active
At
movement. If
rest, the
the
spinal
active
nerve, do
movement
not
is
forget,
painful, it is going to
one
be
can easily
impingement
trick
injury.
movement
If
which is
passive movement is
painful,
also
especially when
painful,
you
or
put
you are not able
biceps
to
action in
bring the
isometric.
shoulder in full
It is
range while
painful,
applying
and
passive force, it may be
your
frozen
athletics
shoulder
also
or maybe
accordingly,
bursitis.
like
If
Dr. Shally
isometric range of
Praspanita is
shoulder
simply referred to
muscles
or
is
with them.
painful, it is
Athletics
mostly the
also
soft tissue
positive,
injury like
and the
tendinitis and
active range was
bursitis. While
complete.
if you are applying body
At the
weight,
same
vertical pressure to
time,
the humeral
doctor
bone,
send it to or refer it
and if
to.
it is
So this is
painful,
the way
it may
from
give you
1982.
some injury to the joint structures.
Near's test from
Similarly, an
1977,
unstable or
and he suggested
instability
the
of
acromion
shoulder
types in patient
may
to
give you a
perform
hint
active
of
movement. If
ligament
the
injury
active movement
or
is painful, it is going
subluxation,
to be
dislocation of the
impingement
shoulder.
injury. If passive movement is also
Never
painful or you
ever
are not able to
forget that
bring
shoulder
the
is not
shoulder in
always a
full
shoulder.
range while
The pain
applying
of
passive
shoulder
force,
may get arise
it may be
from
frozen
some
shoulder or maybe
neurological element
bursitis.
also,
If
like
isometric range of
cervical
shoulder muscles is
spine,
painful,
the
it is
spinal
mostly
nerves
the soft tissue
compression, that
injury like
is called
tendinitis
root
and
compression,
bursitis.
which
While if you
also
are
may give
applying
rise
body
to
weight,
shoulder
vertical
pain.
pressure to the humeral bone, and if it is painful,
Besides, there
it
are
may be
number of tests. In
some
fact,
injury to the joint
when you go through
structures.
some Google material and
Similarly, an
ask Google that
unstable or
give
instability
me
of
the
shoulder
shoulder
may
clinical
give you a hint
examination
of
test,
ligament
it is going
injury
to give
or
you not less than
subluxation,
220 clinical
dislocation
tests to
of the
diagnose
shoulder.
the problem. So it is very
Never
important
ever
to know which
forget
test
that
is more
shoulder.
reliable, more specific, more valid, and more sensitive for the diagnosis. There are a number of tests which are used by physiotherapists in daily clinical practice, and they are quite reliable also, like painful arc syndrome. You all know that Yergesen signs, Hawkins Kennedy test, MT can test, apprehension, and SLAP test. One can easily find that all these tests are following Cyriac's method. Like in painful arc syndrome, you ask the patient to perform an active movement and it is painful in a particular range. So active movement is painful, it may give you hint for impingement syndrome or soft tissue problem. While in Yergesen science, you are you ask the patient for some isometric movement which is painful, especially when you put biceps action in isometric. It is painful, and you end up with the diagnosis of bicipital tendinitis. While in Hawkins Kennedy or SLAP test, also you put a vertical pressure on in which we put a vertical pressure on humerus that it may go and hit the glenoid labrum, and if something is in joint it is going to pain, and you have a diagnosis of either some slap lesion, that is labral tear, labral injuries, or maybe subacromial bursitis. The source of symptom in any shoulder condition may be soft tissue injury or maybe a weak agonist which is not working properly, or a tight antagonist which is not going to perform agonist to its optimal level, or maybe capsular tightness, maybe incompetence of synergies which are helper muscles which are more important than agonist and antagonist, or maybe just a pain that you are not able to perform shoulder movements in complete range. The aim of physiotherapy is either you are supposed to heal the tissue, maybe you are supposed to give stamina to the tissue, strength to the tissue. If it is tight, you are going to stretch it. If some muscles are not triggering at right time, recruit the muscles. Maybe some mechanical derangements are there, or maybe it's some ergonomic or occupational reasons which need to be corrected. Again, I am saying do not forget that it may not be a shoulder, it is because of cervical element that is mimicking into the shoulder pain or the radiating pain. So, friends, the basic of physiotherapy or an approach to physiotherapy is incomplete without the knowledge of biomechanics. It is of utmost important for a physiotherapist that he or she should have a very good command on biomechanics, and especially when it comes to shoulder, we need to understand the biomechanics. So now let's try to understand the shoulder biomechanics in a different way. We need to understand a new SRK, that is shoulder arm kinetics. So let's see that in order to complete the shoulder elevation, that is complete flexion and abduction, what muscles come at what time? What is the sequence of participation of muscles? At rest, deltoid biceps, triceps, along with coracohumeral ligament counteract the pull of gravity. When you are doing nothing, you are at rest, but still they are contracting, still they are in tone phase. You start your shoulder ROM perfectly or with gracefully with leg extension. When glutes are recruited, it is easy trunk to rotate, trunk to extend. Then the real elevation of arm comes into elevation. That is, the scapular retractors and depressors comes into picture, making the shoulder complex ready to fly now. So before you can see that you are raising your arm, all these muscles need to get contracted or need to be recruited in the real action. Like here, our SRK, that is shoulder ROM kinetics, clearly depicting that this gentleman is using the leg extension first, then glutes initiation, then spinal extension and rotation, and there comes the retraction. Maybe because of this, this signature pose looks graceful. Now the real muscles or so-called agonist comes into action because synergist have already helped them to move. First, deltoid translate the head of humerus in upward fashion, which is being facilitated by rotator cuff, which is a synergist for shoulder, that they compress the humerus head into the glenoid cavity throughout the movement. Without them, it is not possible for deltoid that it may bring your arm into full elevation. The glenohumeral rhythm, as you all know, plays very important role in making or shifting the scapula as and when required and how much is required. Everybody knows it is the ratio of 2 is to 1. Besides, the arthrokinematics also plays a very important role in which we need not to forget scapulo rather sternoclavicular and acromioclavicular joint for main glenohumeral arthrokinematics. So using these clinical skills, our dear physios are now able to diagnose their respective patients. Like here you can see in a slide that Dr. Shailen diagnosed it adhesive capsulitis because the passive range was not full, while Miss Nancy Sharma diagnosed it as supraspinatus tendinitis because all the valid and reliable tests were positive and the active range was complete. At the same time, Dr. Aklim found that his patient is a patient of maybe slap lesion or subacromial bursitis because axial compression was painful and it may be some injury of joint structure. Now you have a clear-cut diagnosis in your hands. It is very easy to treat accordingly. Like Dr. Shailendra is treating adhesive capsulitis, where the aim of physiotherapy is to decrease pain and to regain the movement. While Dr. Nancy's aim for physiotherapy for her patient is going to promote healing first because supraspinatus is injured. And at the same time, Dr. Aklim, as his patient came out as a patient of maybe slap tear or subacromial bursitis, he need to send his patient for further investigation like an MRI or simply refer to orthopedics for further management. If it is surgical management or maybe conservative management, he need to send it to or refer it to orthopedics. I always suggest my physiotherapist that the treatment or care of the patient is a multidisciplinary team effort. It is not like I am a physiotherapist, I can do everything. Same is with others medicos also, that you need to know where to stop physiotherapy, we need to know where to start, and we need to know when to refer the patient for the betterment of his or her condition.
So this is the way we have been practicing, and we have been trained to practice like this for clinical tests and biomechanicals. Everything is all right, but we now it's time to see that whether facts are aligned with theory or it's time to change the facts or theories.
So let me put this thing in this way, like in this slide, you can clearly see a poster of a hit movie named Gora and Kala. It released in 1972 probably, and it was a big blockbuster. But how many of us have seen it, or how many of us are going to see it today only because it was a blockbuster? Nobody's going to see it. I think so. And there is another picture of this telephone which we used to use, and we were quite excited about that. We have phone. It was like 80s thing. Now nobody is going to use it. Everybody has mobile and smartphone and internet, and it's good also. The world is progressing. But when it comes to test or clinical test, still we follow empty can test from 1982. Near's test from 1977, and he suggested the acromion types in 1986. And there was a time in 1972 when all the kind of rotator cuff related pain were thought to be because of acromion type only, which you know now it is not the fact, that it is not always acromion which is going to hurt your supraspinatus, and it is not a remedy to cut the acromion so that your supraspinatus become free. Moreover, no test can selectively activate supraspinatus or other muscle or bursa. You cannot selectively contract a single muscle because in any movement, not less than 8 or 9 muscles of shoulder work simultaneously. Of course, in a very synchronized fashion, but they work simultaneously. So, whenever you put somebody under the test and you think that you are putting or asking the patient to contract supraspinatus in empty can test, no, it is not possible. Many muscles, maybe 8 or 9 muscles, work and contract simultaneously. It is very difficult to understand the pain which was provoked by your test was because of supraspinatus or some other muscle. So there is nothing Gora and Kala, black and white in shoulder complex. There are so many colors in shoulder complex which need to be understood. Like RC repair, rotator cuff repair is not so fair. It is not fair that you every time you repair, unless it is a traumatic shoulder, unless it is a grade 3, it does not require repair. And moreover, acromioplasty is a yesterday thing now in Europe, but maybe still practiced in our country. It's like, tell me, if it is plantar fibrofasciitis or heel spur, are you going to cut the heel? Is it the remedy? No. You need to understand the biomechanics that it is not always acromy, and maybe scapular movers are not competent enough. Maybe the pain is because of humeral movement, incompetent humeral movement, or maybe synergists are not working on their time. So there are so many biomechanical reasons for your pain. Moreover, Moreover, 96% of people who are ranging in 40 to 70 years of age have some shoulder abnormality when you put them in test, but they are asymptomatic. The 90% professional baseball pitchers show joint diffusion in their HRUSG and MRI without any
Or
symptom.
you
So
can
one
tell me
cannot be
all
labeled as a
this much
shoulder
force can be
problem or
created
shoulder
by
pain thing because the
effective
fusion is
one
there
your
or some test is found. Being a
Jeremy
physiotherapist,
always
we
insists
all put lot of pressure on our patient for our posture correction. That posture fault is the real culprit. It should be corrected. But in fact, nobody can change anybody's posture. Static posture cannot be changed after the skeletal maturity. Maybe dynamically you can use your shoulder in different posture effectively, but to say that you can correct
being a
your
physician.
posture
Jeremy always
permanently,
insists
especially
put lot
static
of pressure
posture
on our
after
patient
skeletal
for our posture
maturity,
correction.
is
That
not
posture
possible.
fault
We
is
do
the
not
real
have
culprit.
any
It should be
evidence of
corrected.
any
But
techniques which can
in
correct
fact,
your posture
nobody can
permanently.
change anybody's posture. Static posture cannot be changed after the skeletal
The fact
maturity.
which are in
Maybe
hands
dynamically you
till
can use
date
your shoulder in
for
different posture
electrotherapy are
effectively,
really
but to
controversial.
say that you can
We
correct
use
your posture
lot of
permanently, we
electrotherapies,
all
especially
put
in our daily clinical practice, without any evidence. Yes, maybe they act as placebo. That's okay because there is no evidence except a few papers are supporting laser and shockwave therapy for shoulder conditions, but still it is in research. Ironically, few evidence support that electrotherapy may give negative effects on your patient's. Manual therapy has always been my favorite topic, and I always believe that it's my forte. But when we talk about capsular stretching, the fact is not aligned with the theory because it only requires 683 kg per centimeter square force to stretch glenohumeral joint capsule manually. This much force can be created by some Bahubali, but not by some physiotherapist. In fact, the words real Bahubali could lift 500 kg and he became the beast of the champion of weightlifting. So the world record is 500 and we physiotherapists think and say that we are going to stretch your capsule which requires 683 kg centimeter square force. So if it is real that we can create this much force, it's time to switch our profession in some better field like weightlifting. So is it so complicated? What to do for shoulder pathology? Here Jeremy comes. With his so easy, so effective, so rational methods, it has become very easy to treat a shoulder. After a long research of maybe 20 to 25 years, Jeremy gave this theory of shoulder symptom modification procedures in which there are only 10 techniques, you can say them procedures or technique, which on the very first session you are able to know, you are able to recognize the technique which is going to help patient the most. The first technique is finger on sternum, second is humeral head depression, AP and PA pressure, then isometric. These all techniques you are supposed to give patients on the very first day, and the moment you are able to recognize which is the most effective technique for the patient, that is the choice of your SSMP. This is going to help your patient in alleviating the pain. So you assess the most provocative movement or most painful movement of the patient. Like suppose abduction is the most painful movement, you give SSMP to the patient in abduction only and get to know which is the most effective procedure, and you follow that procedure for maybe 10 or 15 days. You train the patient for to repeat the procedure at their homes also, and after 15 days the patient is pain free, rather pain free. Then you apply the higher or superior techniques which is called HSR, that is heavy slow resistance technique. Need to understand when to start heavy slow resistance technique to the patient, that is after SSMP, when you are sure that pain is now not that much, that it is a safe entry point, that you can apply now heavy slow resistance technique, in which the maximum weight which can be lowered slowly but cannot be raised actively is given to the patient. We will see in video that how it is given. Again, remember that rotator cuff is a social tendon, thus all the tendon helps to alleviate the pain if they are treated correctly.
Okay, moving towards our next lecture, that is by the Chancellor
And
of
not only
Gandhiram
the aim of physiotherapy is
University,
to reduce pain,
HOD
it is
Ahmedabad
the
Apollo Medics,
main
that is
duty of a
Such kind of
physiotherapist to
with
make
let
the
us
patient
understand the nature
really
of
fit.
God.
It's not only if you don't have
Opposite
pain in the
MERS,
shoulder you
that
are
is
fit.
the virus. What
The
your
fitness
perspective
is
is
you can
maybe
do your
the bar is
activity of
slow
daily living
abilities mass classification.
during the
without any pain,
services in
without any weakness, without
These
any strength.
I'll
Thus,
treat you know.
Jeremy
Results were checked and
suggested it
counter-checked,
is very
and there were
important to
several
bring your
refined. Now
patient
the
back
present
to
history and
functional
also the
activities and
spine,
fitness
the thumb position, which I
once
is
your
very
patient
important.
is
I
clinically
will
okay. But that doesn't mean it is the end of treatment. You need to give him superior exercise for his stamina, strength, stretchability, including the lower limb and whole kinetic change. That means if you are treating a shoulder, you need to address the lower limb also, because it is not possible to bring out the maximum force from your arm without using your leg. You can see a baseball pitcher throwing the ball. Think, if he does not use his leg in front, he is not going to throw the ball for a long. Or once So these were the techniques by Dr. Jeremy Lewis for rotator cuff related shoulder pain. Besides these techniques, that is SSMP and HSR, then functional activities, Jeremy always insists on the skills which cannot be taught at any college, like communication skills, the way you speak to your patient, the kind of trust you gain from your patient, the choice of words which you are using during exercise therapy or interviewing during the motivation of the patient, they really work the best. With this message, I would like to wind up my session. Thank you. Thank you
Wow,
very much.
what a nice lecture and what a knowledgeable. Okay, moving towards our next lecture, that is by the Chancellor of Gandhiram University, HOD Ahmedabad Apollo Medics, that is Dr. K.N. Annamalai sir. He is General Secretary and IFP. He's going to explain about the physiotherapy perspectives in COVID 19. Sir, it's our pleasure that you are going to explain us about the what a physiotherapy can play in treating the COVID 19.
My topic is, I don't want to say everybody has said morning to evening at least once nowadays. That's called COVID. So I think everybody having a great idea about COVID because the COVID has been created awareness to the nook and corner of the world and entire universe, we can call it as, not in the world, in universe, because such a strong message it has sent to the humankind that don't destroy the nature. With that message, I would like to start my lecture of COVID in the perspective of physiotherapist. Okay, so first of all, general idea about COVID I would like to share, because we all are therapists. We know about COVID more than a civilian, but yet it's my responsibility to explain in my perspective how I am looking after COVID, because basically I'm a critical care therapist, working many years in ICU in the Apollo Hospital. So now I had a chance to serve to the people of COVID. So it's ongoing process right now. So which has been helped me to understand this COVID little better and depth sense of knowledge. Because once we gain the confidence when we treat the patient and the patient get all right, you feel something like take home message that okay, I did something great. So such kind of with the satisfaction and happiness, I would like to just share the data and thought process and what are the challenges we faced and how we overcome the challenges and how the case to case difference and how the acute case rehabilitation, how the prevention and how to improve the immune system and how you have to take an ergonomic perspective. And see, physiotherapy is such a Spider-Man web. It can just pull any direction if you want. So such a beautiful subject. So COVID also got into the spider web now. So we are going to see one by one. I would like to share my screen first.
Dumna madam, please allow sharing in case.
Sharing is allowed, sir.
Yeah.
Thank you.
Yeah. Can you able to see my slides now?
Yes, sir.
Yeah. So first, before I would like to give a small idea about COVID. So first, if you are understanding the COVID perspective, uh, we all are having a phobia and a fear about COVID nowadays, because what we are seeing, actually, there are certain myth and facts are there. I would like to open up the myth and facts first before going into COVID. Let us understand the nature of virus. The first and foremost thing, what is the difference, basic difference between virus and bacteria? See, the virus and bacteria, there are a huge difference. The virus is a non-living thing, actually. The bacteria is a living thing. So that means here I mentioned that living thing and non-living thing difference is the virus cannot be reproduced by its own self, and it requires some medium to reproduce, or it can to establish its contacts. Whereas the bacteria can reproduce by itself, so it is a living thing. So first of all, we should understand that the whole world is getting fear against COVID, which is a non-living thing. So that's why I used to call it as godly virus, because it won't reproduce one more god, and it is just creating hell and heaven of a whack around the world. So the virus is a non-living thing. So then if somebody is already died, how can you kill? So that is a big problem, challenges facing by all our medical partners and pharmacological partners and research people, and everybody is having that problem, that already dead body cannot be killed easily. So that is a very toughest task what the whole world is just facing right now. So I want to say the difference between virus and bacteria. I think you understand that virus is non-able to self-potentially manufacture one more virus on its own. It required a medium to multiply. That's a very important thing. Okay. So the second part I would like to discuss about virus. The virus is a word which we heard since long before entering into physiotherapy field in the 70s and 60s, when Microsoft was introduced the word virus in the software system. So why they call it as virus in the software system, basically? So there should be some synonyms or simile between the virus, which the word which is used, and its physiological function and how it works with pathology, and there is some relation. So I would like to explain with you the first. So this is a round virus, it's a spherical virus. In the spherical virus, you have a lot of spikes. So the spikes are very important, they are actually a kind of proteins. So these proteins can able to clinch easily. It can able to clinch easily, and once it clinch, then slowly it get penetrated into the body. That means it is getting entered into the cell membrane. Cell membrane, because the cell is a structural function unit of your entire human body. Okay, so now these spikes are very, very important. So why these spikes are very important? It looks like a crown. It's a corona word. Corona word derived from crown. It looks like a crown of the princess. So it is a corona radiata. It is just radiating corona all the ways. So it is, that's why it's corona. And this ring is really sensible ring compared to virus, because inside the virus is a dead tissue. It cannot act without the function of this virus around that ring, which is actually spikes. The spikes are a different kind of proteins. All these spikes are fat soluble protein. It is actually fat soluble, means when it just clinch onto your body, in your body you have a skin, below the skin you have a fascia, and you have a superficial fat, a deep fat. So it is a fat soluble, it can enter into the fat easily. So that's why it can travel easily. So this protein which is enhancing the passing into your cell, because it is having a fat soluble nature. That is the beauty of this virus. Whoever designed this virus, even it may be a god, or there is a lot of speculation that it has been made in the laboratories. We do not know. It is not our cup of tea. We don't want to go for that controversy. So whoever designed, it is very sensibly designed, because the outer structure of that corona ring, which has a spikes, which is a specialized kind of protein, which is a fat soluble, it can inject into your body by just penetrating the cell membrane, and that's the beauty of it. And what it happens actually, let us stop it here. Let me just have a simile of your computer. So you take a computer. In those days, we use the word virus. Okay. What is actually virus will do? Suppose I'm just using a pen drive or I'm using a floppy disk which is containing the virus. Once I enter into the system, first of all, this is a virus in the software is something nothing but it is a kind of a program. It is a kind of a program which is a bad program. We can call it as a evil program or a bad program of the computer. So once this program enter into your hard disk or hard disk, what it will do means it will just disturb the basic operating system of the computer, beginner's operating system, basic operating system of the computer. So when the basic operating system of the computer has get disturbed, so automatically you have a block in the computer doesn't work or computer get hang or computer will start to miss, it won't work on your instruction. So this is a normally. So once it become virus, so the entire disk has to be rebooted and the entire disk has to be washed out and cleaned out, and you have to put the re-enter all the things. It will just spoil all the files and totally it will kill the computer. So again, you have to relive the computer by booting the new Windows and Windows operating system. So this is we know about the computer virus. So let us talk to the human virus now. How this coronavirus, this is a very sensible and very intelligent virus. What it does means it just enter into the human body and it is just have a attraction towards a ACE2 receptors. We have a special receptor called ACE2 receptors which just mingle with that receptors. It go into the cell normally, it enter into the cell. So what happens once it enter into the cell wall, suppose this is a virus, it enter into the cell wall. Normally any bacteria enter into the cell wall or anything enter into the cell wall, immediately cell wall will start to react to it and it fight with that. But here what is happening means it won't have any signals to the center of the nucleus of the cell. So it can just penetrate easily into it and enter into it once it go into the cell nucleus. Nucleus is called a structural function unit of entire cell. It enter into the nucleus and inside the nucleus it sit inside and it asks the nucleus to reprint the version of the same virus. It give instruction to the nucleus. So similarly, what I said, the basic data operating system has been killed by means of entering of this program. Same way it is happening. So once it disturbed and it is just start to give instruction, the nucleus of our own cell will start to produce and copy, Xerox copies of this virus more and more. Then it start to spread all over the body. So that's the way the viral load is increasing inside the body. So it's such a beautiful part how it enter into the body and float into the body, how the sensors work, how it enter into it, and again it is reprinting its version. It's almost like what you can call it as Indran version, kind of it keep on reproduce, and start to spread and it fight with your immunology system and it create lot of storms inside the body and very less amount of people are much affected. Okay, this is one of the fact about the virus I would like to discuss. First, we should understand how this virus functions. Okay, I think you all are well with this area, how the virus get function. So now we ask use some soap or detergent to kill this virus. How it works? Let us have some common sense. Okay, what is happening? The soap is again you have a fat in it. It is again having a fat in it, and you have phobia, hydrophobia nature. The soap is having the hydrophobic nature and hydrophilic nature. Both the things it is having. So what is happening means when we use the soap, this protein will work function opposite and it create hydrophobic. So the outside ring get degraded. The outside ring get degraded. Once it degraded, this virus inside cannot be done anything. So that's why we are insisting that use the soap, use the soap, use the soap, use the soap, or use any detergent or cleansing agent or disinfectant. All these things are working in that way. Okay. And the second part is regarding the droplet infection. Initial days, we had different idea. and day by day new papers and new ideas are coming regarding the droplet infection and spread and other things. I don't want to go much with that because everybody become masters in it, because everybody experiencing, a person who is experiencing the disease will become more doctorate in a particular disease than the doctor. I believe in that. So I think we all are just understanding every day with a lot of effort of government orders and all those things. We learn a lot of things. Okay, this is one of the thing. Okay, so now let us come to the point. Okay, let us have an idea about this COVID. Date of birth of COVID is December 2019 is a date of birth, and birthplace where it is born is Wuhan, China. And what is SARS-CoV-2? What is the name of this? Severe acute respiratory syndrome. Severe acute respiratory syndrome caused by coronavirus 2. That's why it is called SARS-CoV-2. And what is a family? It family belongs to retrovirus HIV. Retrovirus HIV. Actually, what is retrovirus means? It can reproduce with a different virulence, and it has going for a different modifications. So updated versions. So that's why retrovirus. Same the family of HIV. It belongs to the family of HIV. And what is the pet name we have given? COVID-19, coronavirus disease 19, December, coronavirus in December 2019. That's why we call it as COVID-19. Who is his brother? The family brother, they have a lot of family friends, family members, but only one more brother was famous in between. It's called MERS, MERS. That is Middle East Respiratory Syndrome, which was started earlier, little before than COVID, and it has created some impact in the world, but not us like COVID it has been, but he is an elder brother, MERS, that is the Middle East Respiratory Syndrome, was caused by the same family member. Okay, what is the status of coronavirus as such up to yesterday? So 80,000 cases in a day we are increasing. So I think we are reaching the world number 1 now. But compared to world population, I think we are just doing good, and we are not having a very heavy load right now. It is actually, see, what is the thing means, we do not know clear about whether we are going to create a herd immunity, or we are going to get a right vaccine, or we are going to get the right medicine. We do not know. But we know that how to prevent ourselves, and once it come, how to manage and how to come out of it. That is the way we have idea. So up to August 30 yesterday, we got 80,000 rise in India a day. It's a very high rise in new cases. Okay, now I'm going to talk about ACE2. ACE2, the spikes protein I said, you can see in the picture spikes protein, SARS-CoV-2 and cell membrane. The infection is just getting through a ACE2 receptor. So it is called cellular entry. So cellular entry and binding of spike protein, receptor binding domain, that is called RBD, receptor binding domain, and ACE2 receptor due to affinity, because ACE2 receptor is having high affinity to CO2, COVID-2. So that's the reason ACE receptor is getting a very important limelight nowadays. Okay. The most fatality rates in the respiratory complication, I give the lungs as a number 1 score, because which is rich with your ACE2 receptors. So ACE2 receptors, where and all there. If you see, our oropharyngeal area is rich with ACE2 receptors. Then if you see, all the blood vessels are rich with ACE2 receptors. Kidney have some ACE2 receptors, and you have lungs is enormous ACE2 receptors. So these are all the areas commonly getting affected by COVID. So the lung is a very sensitive organ to COVID, because the alveolar epithelial type 2 cell rich in ACE2 receptor. So alveoli, in the alveoli outside you are covering with the basement membrane, and the basement membrane is actually given with a lot of pulmonary arteries and veins, and these pulmonary artery and basement membrane, in between you have lot of, you can see in this picture, this is actually your alveoli, and this is your capillary vessels, and these are all the basement membranes, where this area is rich with ACE2 receptors. So what is the beauty means? The COVID-19 is highly vulnerable to this area. It indicates inflammatory cascade. Inflammatory cascade means like a waterfall. The inflammation keep on continue fall, increasing, 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 increasing. It's like a merry-go-round. The inflammation will increase. That's why it is called cascade. Initiate an inflammatory cascade as a part of immunity combat to infection. So infection to again to fight or combat the inflammation starts. We know that inflammation is the healing process of the body, but unfortunately, here the inflammation triggers continuously, keep on healing, keep on healing, keep on healing. So every inflammation followed by healing, but inflammation is bad for health. So the keep on cascade of inflammation is reducing combat of infection, which is part of immunity is going down. So the inflammatory cascade, if you see, there is a lot of pro-inflammatory mediators. What are the lot of pro-inflammatory mediators means? To stimulate more inflammation. Pro means to stimulate more inflammation. There is a lot of mediators like the COVID will go and just stimulate. So different kind of cytokines and chemokines will start to produce. The cytokines means the cyto means cell, kines means movement. It is done by some ACE. ACE means it is something like an enzyme. So cytokines and chemokines, and which create more and more and more and more and more and a cascade or a merry-go-round of inflammation, which create a permanent fatal insult to the lung. So the lung tissues are just getting destroyed, or it is permanent fatal insult to the lungs. So this we call it as cytokine storm. What do you call it as? Cytokine storm, because a lot of cytokines are flushing and creating a storm. And this is the main reason for sudden death or young people death or sudden inflammatory has been increased. So the maximum among 5% of the population are fatal. In that 1.5% is highly fatal and they are dying, and immediately they are dying. That is, they are not giving time for us to work on the patient because of cytokine storm. So main cytokine IL-6, which is called interleukin 6, and 1 beta elevation directly linked to the disease severity. So what you can do means, if you find out the interleukin 6 or interleukin 1 beta, if it is elevated, then you can see that the disease is highly severe. So this is what I call it a cytokine storm. So you can just understand that how the storm happens. So you can see that these are all the dendrite cells, right? These flower-like cells are called dendrite cells, and these are called lymphocytes. These are all lymphocytes, and this is these are all the virus. These are all COVID viruses. This yellow color, and once it goes, it produces an inflammatory reaction, chemokine and cytokines, and chemokine and cytokine, and these are all the macrophages and neutrophils. So once it creates a storm, this is called actually cytokine storm. So this storm will permanently damage the lung part. Okay, global pandemic. Most patients with COVID-19 have mild symptoms. Most patients. So that's why the beauty is, it is there is a joke which I have seen, that when the phobia of COVID will go away, or when the COVID really will go away, what kind of lockdown we should put. They say that the lockdown is not to the people, we have to put lockdown to the media, because the reason is it has been distorted in a different way and different textures for TRP is concerned. Because of that, the COVID is taken in a very big nature. It took a Viswaroop, we call it as. So most patients with COVID-19 have a mild symptoms. Don't want to fear at all. It's a very, very mild symptoms. Even some people do not notice that they got a COVID. And about 5% develop severe symptoms. They are very, very crucial and critical patients. We cannot leave them, which can be included acute respiratory distress syndrome. We call it as ARDS or stiff lung disease, and septic shock and multiple organ failure, and they become fatal. And many patients nowadays, they found out the kidney involvement is very important, which is there, which is called as acute kidney injury, or you can have a mild proteinuria, and it is a progressive. It is secondary because of it is involving in the epithelial tissue of the arteries and veins. So this is a very beautiful picture which can be shown that one is a cytokine storm, and it can cause pneumonia, that is ARDS, and also it can cause hypercoagulability. That means it is affecting the epithelial cells of the blood vessels. So because of that, it can create hypercoagulability, that is called clot. So that's why the clot is also one of the reason for most of the myocardial dysfunction, and also endothelial dysfunction is a reason for your kidney problem, and ARDS is directly attacking. So these are all the three different area where how the COVID can involve in your body. Either it can create a cytokine storm and endothelial dysfunction, or it can create a cytokine storm, it can create a pneumonia, and also it can affect the kidney indirectly, and or it can create a hypercoagulability, it can affect the heart, or again it can affect the pulmonary hypertension it can create. So this is a beautiful symptom which is a correlation of your lungs, epithelial cells of your blood vessels, and heart and kidney. So this is the areas, that's why we call it as MODS, multiple organ disorder or dysfunction or failure can happen with COVID. So now what is the beauty? This is actually CT chest of COVID patient. So you can see one beautiful thing. You can see ground glass opacity. That is opacity over there. In the computerized tomography of this chest, you can see that the beauty is, see, this is your center part of your parenchymal tissue, and this is a peripheral area of the tissue. So peripheral tissue, you have a fibrosis. You can see the peripheral fibrosis. What is the cardinal sign of CT chest is peripheral fibrosis. Why it is peripheral fibrosis? You see that you have here lot of ACE receptor, and you have ACE receptor at the each alveoli. So alveoli is at the distal end. It is not go through the bronchi or bronchioles. So it is at the distal end. So when I cut the chest like this, so at the distal end of each alveoli is at the periphery of your lung. So that's why, because of the ACE receptors are rich in the alveoli, so you have a what you can call it as the surrounding tissue of your lung. Basically, central parenchymal tissue does not have any change much. So most of the change will have a fibrosis at the peripheral area of the lungs. Okay, then it is a very, very common, and everybody now know, like diabetic test, RT-PCR, because everyday media is pronouncing and everybody, neighbor is saying RT-PCR. Now RT-PCR become a very normal civilian domain term. So what is RT-PCR? Reverse transcription polymerase chain reaction. This is the expansion of RT-PCR. So, as a physiotherapist, what you should understand means, if you want to understand the severity of the patient, or if any of the relatives you would like to understand, or even if you are going for a COVID test for RT-PCR to the laboratory, you can ask one question: what is CT value of RT-PCR? CT value. What do you mean by CT value? CT value means cycle threshold. It is a cycle threshold. You should have one idea that 24 is ideal. What is that? 24. If it is less than 24, suppose the CT threshold lab fellow is saying that you have 18 or 17. So that means the viral load is more on this body. He is going to be a great spreader, super spreader. So basically from him, you have to take a lot of precautions. So when you want to treat the patient post-COVID, or you want to prevent the COVID, or during the time you are happen to have RT-PCR, if you happen to understand what is the CT value, if it is less than 24, you should take lot of precautions to treat the patient. And if it is more than 24, suppose 28, 29, 30, so less chance of spread, which is a low viral load in the body. So this is a very, very crucial thing. You should understand that what is cycle threshold, and CT RT-PCR 24, less is more chance of spread viral load more, higher is less chance of spread less mode. Okay, now let us talk about physiotherapy perspective. Sir, now we talked about COVID, what is the situation and how to understand. In CT scan what I should see, RT-PCR what I should see, what is CT value, 24 above and 24 below, what should I do, why I am washing the hand regularly, and because it's a hydrophobic, and all the things step by step. Now we see the physiotherapy perspective. So what are the 4 things the COVID can disturb? So now we have started a program of post-COVID rehabilitation in our center. So mostly 3rd week or 2nd week of post-COVID, we are taking the rehabilitation part. So we are taking a patient of subacute to and chronic. Subacute we are taking in the hospital settings, and chronic and subacute, and after that the patient post COVID negative we are taking in the clinical settings. So what are the four physiotherapy perspective regarding the COVID? This is our own experience and ideas from different part of the world we collected and inculcated over here. First one is endurance. So endurance, strength, independence, and safety. These are all the four things regarding the physiotherapy perspective. Okay, what do you mean by strength? If I can just lift this ball, it is my strength. So how many times I can lift up and down, I can hold for? That is called endurance. And suppose I can able to walk, it is my strength. How much distance I can able to walk, that is the endurance. And independence means I don't want any support. Here the supports are totally different. And safety, it is not your safety, it is own patient safety as well as the other safety. Here the safety is different, independence is different, strength is different, endurance is different. That's why I said that the physiotherapy in the COVID perspective. Okay, let us talk about the physiotherapy perspective of endurance. Okay, so primary post-acute care. What is primary post-acute care means? A patient come into the hospital and we are working in ICU, and in the ICU the patient is with a severe stroke, cytokine storm, or patient is in the kind of comorbid or something like that, or patient is just symptomatic and staying in hospital. And what is the primary post-acute care we will give? First and foremost is the patient have a ICU acquired weakness. So ICU acquired weakness means the mobilization will be tough and your muscle will be weak, and patient is just completely, because of viral load, the patient will have completely dull and aches, pain, irritability, all these things will be there. We call it as ICU acquired weakness, and we otherwise we can call it as post intensive care syndrome. It is called PICS, post intensive care syndrome. The most of the patients what we have seen in COVID is in post acute care, mostly they will have twin problem called dyspnea and oxygen desaturation. Dyspnea means difficulty in breathing, and also oxygen desaturation means even a small movement if they perform, the oxygen will drop. The saturation of probe, you can see that SpO2 will drop. These are all the two eyes which you can see in endurance perspective of physiotherapy. That is dyspnea and oxygen desaturation. What about the strength? If a patient is normal ICU patients, comparatively in COVID patient, the muscle mass loss is very fast, which we found out. So the muscle mass is falling very fast, and we see the reason why the atrophy is more faster than the normal ICU patient than the COVID ICU patient. We will see the reasons behind. So there is a loss of muscle mass which we are seeing. And the other physiotherapy perspective is independence. The very important part is early discharge to free up the hospital space. Nowadays, the over number of patients are increasing. So the hospital has to do a cyclic rolling because the beds are not available. The population comparatively, the population in geometric progression, whereas our hospital beds are less than the arithmetic progression. So basically, we want to discharge the early patients to give a care to the really much needed and intensive patients. So because of early discharge, the patient almost go on a subacute care. So the patients are not fully independent at home. So they need support of physiotherapy for some time, for extended period of time to become at least to a minimal capacity. And sometimes subacute is hard for independence. Sometimes subacute is hard for independence. So if it is independence is very hard, right? Because some subacute, if you send to home, they need a person, but they have to be isolated. They will be in a room. They have to get up. They have to walk. They need some support. They have to go to bathroom, and they should not sleep. So the independence is a question over there, because the normal people cannot support, because they will keep the distance away from it. Early discharge and the patient of full independence is not possible at home without the help of people. So how much they are going to take care of them and how much they are going to take of their own safety, all these things are a question. So that's why here the physiotherapy perspective, the independence is having a different role. And the physiotherapy perspective, if we talk about safety is concerned, the one is a therapist safety, other one is a patient own safety. So here the weakness is there. There is a chance of fall and decreased endurance and decreased independence and put them greater risk of fall. So the more chance are falling because mostly COVID is affecting the age-old population. Already they are compromised with the Berg balance score and their balance has been reduced and muscle weakness were there already, and also they have a low endurance capacity, and all these things are just a cherry on the cake is your COVID. So the COVID in that the people, the home members cannot support them unfortunately because they have to keep their distance of their own safety. So these all these things are going to affect their safety. Okay, now let us talk something about oxygen regarding the COVID in the perspective of physiotherapy. Most of the patients with COVID 19 will require oxygen supplementation for post acute care. Most of the patients, I'm not saying less patients, most of the patients. The goal to take out of them oxygen support. What is the challenge of the first challenge of the physiotherapist on post acute care rehabilitation is how to deactivate or slowly withdraw the support of oxygen. I said already that here the support means not only orthotic prosthetic support, the oxygen is also a support. So we have to slowly wean off the patient from oxygen. The oxygen saturation should be monitored very closely because even a small movement also will go for a deconditioning effect and create oxygen depth, and immediately patient will go for a collapse. So oxygen saturation should be monitored closely, SpO2. Okay, what is a very important area about the strength? The specific viral load. Few viral load will just kill the strength very faster, and a certain viral load will just have slow sustaining losing of strength. So the specificity of viral load will be responsible for the strength changes and prolonged lack of oxygen to the muscles. So nowadays we are just using the mask every now and then for our safety is concerned, and the children who are born in this era, they may feel that it is a private part, that's why we all are closing, maybe in the future. So such a way we are closing throughout the day when we are outside. So what is happening means it acts as a rebreathing bag. Whatever carbon dioxide we just thrown out, the little bit of CO2 is just get sucked inside. So this actually reduce your oxygen capacity, and the muscles are getting a very less amount of oxygen. So that also cause normally even a mask habit is also creating a little bit of muscle weakness, and moreover prolonged lack of oxygen to the entire body because of the COVID and because of lung affected because of ARDS and epithelial cell changes at your what you can call it as your um, alveoli. All these things are changes in V by Q mismatch, and due to V by Q mismatch and pulmonary hypertension, the end of the cell does not get the right kind of perfuration. So because of that, the cell will go for a low oxygen. So the mitochondria will be less powerful. So this can leads to a oxygen depth in the muscles. So muscles can go for dying. That is called atrophy of muscle. The longer period of increased respiratory rate and heart rate and decreased partial pressure of oxygen, that is saturation, and prolonged bed rest, these are all the various reasons for reduction of your strength. And what we can do, how we can test. So we can use the muscle test traditional guideline. So how we can see, first we have to see the anatomy of the muscle. So we have to see the anatomy of the muscle. We should have an idea about comparatively before COVID what was its muscle nature and what is it right now, and how much the growth of the muscle has reduced, and what is you can use a MMT scoring, manual muscle testing scoring, which is a very traditional guideline, and these two things has to be taken care. And functional strength assessment is also very important. While gripping or grasping or just punching or pulling or pushing, what is a functional strength assessment also you should look after. And the loss of weight and loss of muscle mass should be taken into account. So here you cannot consider all the muscle wasting because of that, or loss of muscle wasting or loss of muscle mass or loss of body weight. So here the body weight means it included muscle, that is a protein, as well as other components like your fat and other things, and fat and fluid level and everything. So we should find out whether the patient is having a loss of weight or loss of muscle mass. Two things are very important to identify and have a different accountability for treating it separately. Now let us talk about the independence. So if you want to find out really right way of independence of the COVID patient in acute post-acute care, first you should look for Barthel index. The Barthel index will give you the activities of daily living, how much he can able to operate, what is his tolerance capacity. You can go for 6-minute walk test to identify, and transfer mobility grading, whether he can able to transfer independently by himself or he needs some assistive device. And assistive device here including your oxygen mask or BiPAP or saturation has to be monitored regularly. All these things are also here assistive device. Family support, and how the family is supporting, whether they are just completely neglecting the case or they are just over cooperating with the case, which is also again a drawback for developing the oxygen depth in the body. And environmental support, all this thing has to be taken care. And let us have an idea of safety. Teach patients self-monitoring of the vital signs and other symptoms, because here the very important thing is you cannot be around the patient always, because your safety is also very important. The more amount of exposure to the patient with you, you will have viral loading more. So always you should teach the patient how to monitor his BP, how to check his heart rate, what is his Bohr score, what is his saturation level, how to monitor which is actually alarming saturation level. Once saturation level is alarming, what he should supposed to do, and he should understand what is fatigability, and he should know changes in temperature of the body. All this thing you should teach them, whether they can self-monitor. It is more easy for the patient for the outcome measures. Okay, now let us find clinical perspective of physiotherapy. So clinical method to find endurance. First, you look for shortness of breath. Whether the patient is breathing, suppose you're asking, what is your name? My name is Murugan. So what is happening? He's just using a shortness of breath. So how much he's just using a breathing? Is very fast, shallow breathing, or is a rapid breathing? You should identify. And signs of pallor. Any cyanosis is there. The patient is very what is sluggish and response is low, and the salt imbalance is there. All these things are very important. And baseline dyspnea progressive with mobility. Suppose patient is coming to me and I know some dyspnea is there, so I can just see that whether his saturation level is how much saturation level. So once a saturation level is fine, and when I start to do exercise again the saturation level is dropping very fast, then baseline dyspnea progressiveness with mobility has to be identified. And postural controllable hold their head or trunk up. So in order to keep their head and trunk up, they need a good effective role of diaphragm. Diaphragm is a twin joint muscle. It is a twin function muscle. It is maintaining your posture, upright posture of your body. Same time it is functioning for your breath. So suppose in COVID, due to the challenge of oxygen depth, if it is recruiting lot of diaphragmatic shallow breathing activity, so diaphragm lose its postural function. So the patient may feel sluggish or fall or something, not able to keep your head high or spine high. So that postural control has to be looked after. And breathing pattern should be looked, whether the breathing pattern is very high breathing pattern or easy and effortless breathing pattern or slow effort breathing pattern, that you should look after. And adaptive device and equipment utilization. So whether the patient is comfortable with continuous monitoring of saturation or continuous given of oxygen, or with the BiPAP, we have to look into, or something like a, you need a stick or a cane, or he is having a, or he's having a what he can walker or something. And functional mobility skills. So how much he can able to mobile by himself, how much he need a support from the family. And the activities of daily living in the and bed mobility, transfer, ambulation, all these things are clinical perspective of physiotherapist should just notice. Okay, what is a physiotherapy perspective in nutshell means? Mobility, strength, endurance are the three parts. So simple. So if you have a low strength in small muscles, normally small muscles will lose the strength fast. So strength is losing automatically. You cannot walk for a long time. So endurance will lose. So once the endurance is loose, your mobility will lose. Once the mobility is loose, further strength will lose. It's a vicious cycle. So we have to attack at one quadrant to reach the patient in a better way. First, whether we have to work on strength, then we have to work on endurance. Automatically, the outcome product is mobility will increase. So how you can just able to do, what is the scoring sheet you can just use? Modified Box scale can be used to understand the patient, how he is expressing. That means is actually in 8 to 10 is a very dangerous zone. That means your mobility should be micro mobility, and slowly you have to build up the endurance. Suppose the patient is between 5 to 7, you have to be give a little conscious challenges. Suppose patient is from slide somewhere to 2 to 4, then you can just reach to the challenges level of threshold. And 0 to 1 means you can just go ahead with all your equipments and all your regular rehab work and everything you can do. Okay, what are the consideration regarding the oxygen is concerned? First, we should understand, did patient use before COVID oxygen? Some patient may use the oxygen before COVID also, we may not know. So in that patient, we cannot fight to get the lungs better than the before. It is not possible because already the COVID has created a cytokine storm and insulted the lung. So it is not easy job. So we should understand the pre-history, that did the patient use COVID oxygen before COVID oxygen usage, and less or more or now comparatively. Before, if they use less oxygen or more oxygen comparatively to now, we should have that idea. And use for all activity and rest continuously. Suppose a patient, we are giving a domiciliary oxygen or a nasal prong or a mask or a venturi mask, or you're giving a breathing bag or whatever it may be, you should understand that whether the patient saturation is dropping with oxygen during all the activity or during rest continuously also. So if the patient is having a desaturation of SpO2 even at rest, then it is called newer classification grade 4, which is a very severe patient. Suppose a patient is having a desaturation happening when he is doing exhaustion activity or something. So then it is actually, if it is a 4 means, yeah, and if the patient is having activities of daily living, he is taking bath or he is just going to bathroom, is getting breathlessness, then newer classification 3. A patient is going for a marketplace, cycling or running or walking or star climbing, then it is a grade 2. And a patient is having, suppose, for example, even normally when he exhausts too much on sports, then it is grade 1 of newer classification breathlessness. Either you can use newer classification breathlessness or you can use a book score classification. But I use newer classification, which is more easy in my perspective, whereas in patient perspective, the book score is much better. The use for all activity and during activity only, whether the patient required oxygen or while sleeping also patient required oxygen. What is the prescribed level of oxygen? What is the delivery method? That also makes sense. If you have a nasal prong or you have a mask or you have a Vinci mask or you have a rebreathing bag, that's very important. You should understand. Depends on that, you can titrate the oxygen and saturation for your activities. What is the resistance training? This is for your strength. So here I always use your gravity as a resistant training unit for initial, because you don't want to sanitize anything, you don't want any equipments, and the isolation can be done easily. Like simple exercise like sit to stand, or you can just stand and walk for a few steps and marching at the same place, and use your wall pushing or something, like use gravity. And free weights, if you have a personal TheraBand, personal weight or personal sandbags, you can use, or water bottles of you personal can be used. And functional movement training, you can give a lot of functional activity as a movement training, that you walk up to the kitchen, you walk up to the bathroom, or you just take off your own shirt and just you can use it. And consider the activity induced hypoxia. What are the activities and how much metabolic equivalent is required, which is creating hypoxia, has to be compared with the metabolic equivalent scale, MET scale. And quick to fatigue, which activities are fatiguing him quickly. You have to create that activity be done purposefully with breaks. So that is very important. And low weight, more repetition is a key in COVID rehabilitation. Low weight, more repetition. Progression based on the patient response. It is nothing dictum. It is purely depends upon the patient response, because it is a highly dynamic disease.
Moving towards our next lecture, that is given by the Dr. Masrat Shafiq. He is the CC member of North Zone NIAP. and giving the services in Directorate of Health Services, Jammu Kashmir. He is going to explain about the manual therapy overviews with the spine context and demonstration of useful techniques.
Hello and welcome to upcon Physio nexgen. As they say, where there is a will, there is a way, and this has been aptly proved by the organizing committee of upcon. One of my dearest friends, Dr. Sudeep Saxena, the organizing chairman, Dr. Parashar, and also the secretaries, organizing secretaries, Dr. Sanjay Shukla and Dr. Reena ma'am, and the rest of the organizing committee of upcon. Salutations to you for continuing the legacy. You have continued the good work, and we hope that this effort bears fruit. And it's a very good opportunity for people, particularly students and freshers, who are always on the lookout for trying to get in-depth knowledge into various topics, and you are able to get these beautiful uh, or top-notch speakers that the organizing committee has roped in, and the lectures, I am quite sure, will be helpful to all the people for refinement and taking the skills to a higher level, which will ultimately help them in attaining proper and higher practice and patient satisfaction. Now, without taking much time, we will go into the deliberations. The topic that I have taken is mobilization. First introduction. Myself, Dr. Masarat Shafi, physiotherapist from J&K. I am the IAP CEC North Zone 2020-2023. I am working with the Directorate of Health Services Kashmir and also physiotherapist at a Kidney Urological and Research Center with an experience of 20 years, 19 years. When we are taking manual therapy, the reason for this is that it is a beautiful art wherein you can treat patients with hands-on approach. See, you go to some place, a particular government office or any gathering, and you will definitely end up with people saying, we have got a low backache or a cervical pain or my joint is stiff and all that stuff. So at that time, you cannot just tell them, so I have got nothing and you will have to come to my clinic, or that you will say that I'll get my machines and then only I'll treat you. No, you should have something in your hand wherein you can give on the spot relief to the person, and that will inculcate a belief of trust, and the patient and the person will feel that the physiotherapist is capable enough and worthy enough a person in whom I can trust my health in. So manual therapy gives on the spot relief, and it helps in alignment and proper alignment of various dearrangements of the spine and also the appendicular structures, wherein this alignment cannot be achieved by means of modern medicine. Now, when we talk about manipulation and mobilization, it is not something new, it is very old. We call these people bone setters. We have in our old age, we had these bone setters where people would go and they will start going doing bandages and all that stuff. See, they will also do these particular techniques wherein people will get relief, but these are techniques wherein there is no proper evaluation or assessment or prior examination. So what happens is that the techniques, they can sometimes give you good relief, but sometimes they can exacerbate the condition because there is no scientific approach to it. Now, these techniques in the early part of the 20th century, they were used by various eminent personalities like Maitland, Mackenzie, and other professionals, and they took this to a new level, used the scientific approach, and there was a lot of work which was done on the field, on the ground, and the results were published, and these results were checked and counter-checked, and there were several refinements which were done over a long period. And with that, we ended up with the modern concept of mobilization and manipulation. So now what we talk about is manipulation, mobilization. Basically, it's techniques for treating the dearrangement of spinal segments to get favorable results. Now, what are the indications? See, the indications of mobilization, as I said, mobilization can be done for the appendicular as well as the axial structures. Now, today we are only talking about the spine. So, when we talk about this, we see we can give mobilization and manipulation for low back ache, we can give it for sciatica, we can give it for cervical brachyalgia, and we can also give it for localized cervical pain. So we'll be concentrating on these things. Now, what are the contraindications? I say before doing anything, we should know wherein we are not supposed to interfere using mobilization and manipulation. These will include, see, vertebral basilarity insufficiency, tumors, pregnancy of in case of lumbar spine, osteoporosis. Why osteoporosis? Because the bones will be very brittle or they'll be having lack of calcium. So abrupt certain movements, they can cause harm to the patient. Ankylosing spondylosis, caries, that is TB of spine, any malignancies, is sometimes listhesis of the spine. So these are some of the contraindications wherein we are supposed to prevent ourselves from interfering using mobilization and manipulation techniques. Now, before going into mobilization and manipulation, as I said, we have to go for proper examination, evaluation, and investigation. Now, what will be the investigations? It will be a radiological investigation, it will be a DEXA scan, or it could be an MRI. So, at least minimum an X-ray, minimum, that is the bare minimum, that before going into mobilization and all, you should go for an X-ray of the spine. Now, what will be the assessment? As I said, we go for proper assessment and evaluation. Now, what will be the assessment? It will be listening and believing the patient. That is, we have to listen to each and every aspect of the patient. Sometimes the patient says that I'm having low backache, and then suddenly he'll say, when I'm turning in my bed, it causes pain. So anytime when the patient tells me this, when I'm turning in the bed, I get low backache, immediately something hits in my mind is that it could be an SI joint pathology. So these are some things which you have to understand and use your experience to get these small points which will guide you to the ultimate target. But what is important is that you have to listen to each and everything that the patient is saying, so that you will land up on the proper diagnosis. Now, the present history, the past history, what the patient is having right now, and has he had any episode prior, and what was the treatment that he took before which gave him relief. And then we have the predisposing factors. We ask the patient what are the conditions wherein you were having more pain, and what are the conditions or positions wherein you were, or factors wherein you get relief from the pain. Now, then we take the detailed assessment of the spine. So what we do is we go for flexion, we go for extension, then we go for lateral bending from left to right, on that is both sides, and also we go for a particular mobilization examination, that is a combination of movement, that is extension, rotation, and side bending to right, and extension, rotation, and side bending to left. Excuse me. Now, what are because we don't have much time, so I've been told to go for 20 minutes, already 8 minutes elapsed. So what are the various techniques? So there are various techniques. That simple mobilization techniques will be the posterior anterior central vertebral pressure. I'll be demonstrating that, not able to demonstrate, I'll be showing the photographs for it. We have the central posterior anterior vertebral pressure. Then we have it is given for bilaterally distributed symptoms. For example, when you have pain on both the sides, so we use posterior anterior central vertebral pressure. Then we have the posterior anterior unilateral vertebral pressure. Okay, so where do we use this technique? It is to be used when we have unilateral symptoms. Then we have the transverse vertebral pressure. I'll be showing all these techniques later on. So what we have is transverse vertebral pressure. It is given when we again have unilateral distribution. It is more effective for lumbar and thoracic spine than as compared to cervical spine. And rotation. This is one of the most valuable techniques which helps in treatment of radicular pain. That is pain originating from discogenic origins, and it gives very, very good relief. Now, if we talk about the key points, see, when we are giving mobilization, what are the various key points? See, mobilization we use a rhythmic oscillatory movement. Okay, see oscillations, and for doing mobilization, uh, there are different techniques. Sometimes people use the thumb, and sometimes we use the pisiform. In the cervical spine, it is better to use the thumb for giving the mobilization, and for your lumbar and dorsal spine, when you are giving unilateral posterior anterior vertebral mobilization, it is better to use your pisiform. The vibrations are to be given in sets of 20. There are various approaches to it, but the one which I like, and I follow the Maitland approach, it is a vibration of 20 sets. How do we do it? So we do continued oscillatory movement of 20, then we relax, then we do again 20, relax, then we do again 20 and relax. So there is one key point, is that when you're giving this posterior anterior vertebral mobilization or unilateral posterior anterior vertebral mobilization, don't only go for treatment of the spine which is involved, which you think is involved. You should also go for mobilization of the vertebra which is above the involved segment and one which is below the involved segment. Okay, so that is important. Now we have to go for correction of the predisposing factors. We have to ask the patient all those factors wherein they feel that they are having pain, they should be removed, and all those factors wherein the patient is getting relief, they should be encouraged. For example, a patient who is having low backache or a person who is having discogenic pain, you can tell them to sleep in the side lying position with knees flexed with the pillow between their legs. That will give them relaxation. And also mobilization will not help when you are not taking care of the underlying factors. For example, a person is having tight hamstrings. What tight hamstring does is it will cause rotation, posterior rotation of the pelvis, that will cause obliteration of the lumbar lordosis. So when these things happen, irrespective of how much mobilization you give, if you're not taking and correcting the underlying predisposing factor, you will not get the relief. Sometimes the patient will be having hyperlordosis. So in that case also, you have to correct the hyperlordosis. Only after that, your techniques that you will be giving will give you good relaxation. Now, how many times do we do the mobilization? It is advisable. Some people say that after 24 hours of the first session, and some people say after 48 hours of the first session. That is, if I'm giving mobilization today, I will give the next mobilization not tomorrow. Some people say day after, or some people say we will not give twice daily. We will give only after 24 hours. But universally, it is accepted that after 48 hours it is better. Now, why they say it? See, if I give mobilization to my patient today, I tell them that tomorrow you will have an exacerbation of the symptoms within the first 24 hours. That is, you will feel say maybe muscle soreness or increase in the intensity of pain. And usually, say for example, today I have done the mobilization for my patient. Today afternoon I did it. So I explained to the patient, today night you will be painful. You may have increase in the intensity of pain, but tomorrow morning when you wake up, you will feel much lighter. And this is very important, because if you don't tell the patient like this, what is going to happen is they will start complaining tomorrow, and they will tell you that I had a lot of pain. So you have to make them understand you had pain yesterday, and you have to make them understand beforehand the pain was because there was mobilization given, and there was the soreness effect of the mobilization. As such, it was supposed to have an exacerbation, but tomorrow morning the effect of the mobilization would have set in and you would be better. So you have to make the patient understand. And also centralization of symptoms, that is, when you give mobilization, the peripheral areas from where the pain is originating, there will be increase in the intensity and duration of pain, but the radicular symptoms, they will be decreasing. This is very important. Now, because it's only 13 minutes, so I will go into techniques. Just 1 second for that. Okay, I hope I have, yeah, I'm continuing. So now, so if we see this one, this is a technique wherein we are using the hands. I'm using my thumb, and I'm doing for the cervical spine, and I'm using it the posterior anterior vertebral mobilization. Again, as I said, it is to be given in sets of 20, and one vertebra above and one vertebra below it. And this is a PA glide for the cervical region. Now here I'm using a lateral glide. Say for example, what we do is, in this one what we do is, we give a lateral pressure to the vertebra. The pressure is given from the left side and on the right side. Say for example, I am giving pressure from the right side and it is painful. That is when I am giving pressure to the spinous process from left to right. It is right to left, it is painful, and the opposite is not painful. So what we do is, the glide which is painful, it is not used as a treatment technique. The glide which is non-painful, that is the one which is used as a treatment technique. That is, if my right to left glide is non-painful, I will be using it as a treatment technique. So this is usually given for unilateral symptoms. Again, this is the transverse glide that I was talking about. So we give it from one side. Say in this one, the patient is in prone position. I'm giving the glide from left to right. If this is not causing pain, I will use it as a treatment technique. This is the hand placement for the thoracic spine. As I said, since thoracic spine, excuse me, it has a more bony curvature and it is more hefty, so thumb sometimes is not able to give the desired effect, so we use the pisiform and we extend the elbow and use the whole arm for giving the desired results. This is a PA glide that I am giving, the PA glide that I am giving for the thoracic spine. Again, this is a transverse glide that is being given to the thoracic spine. Now this is a hand positioning for therapists for T4 syndrome. So what you do is, I am using my thumb and I am taking it inside the plane of my hand. This is the position where this T4 syndrome is something like when a patient is having severe pain in the dorsal spine, and you palpate it and you feel that particular point that is very tender on touching. So what you do is, this is the position wherein the patient is asked to attain. I take the patient in the sign like position and use the thumb position which I initially showed and put it exactly the contour, the high point of my thumb will be placed just below the most involved vertebra, and after that I take my hand and put it on both these arms and I ask the patient to take a deep inhalation, and I ask the patient to exhale very fast. When he exhales, in this case I use my left hand which is on the elbows of this patient and I give a downward thrust. When we do it, there will be a crackling, that is a crepitus, I mean not the crepitus, a crackling popping sounds which will come out, and patient gets very good relief from that. This is the hand position for the lumbar spine. Again, as I said, the position is used keeping in view the high musculature of the lumbar spine, so the pisiform is used. The pressure is giving from top to down. Again, a lateral glide, but lateral glide you cannot use the pisiform because you have to isolate the spinous process, so you use the thumb. The rule will be the same. The glide to which it is not painful is used as a treatment technique. This is a unilateral posterior anterior vertebral pressure. So what you do is, not on the spinous process but lateral to the spinous process and slightly above, you will take the point and you will do the mobilization. It is done for unilateral symptoms. For example, if a patient is having pain in the T4 area, sorry, the L4 area, so what I do is, on the right side, so what I do is, on the L4 area I go lateral 1 or 1.5 inch, then slightly up half inch or 1 inch, and then I do the mobilization, and this helps to resolve the unilateral symptoms. This is the central glide for the lumbar region. Now this is one of the techniques, as I was talking about the rotation. So what I do is, this will be the starting position After that, see, this is very important. The lower leg is slightly flexed at the hip and slightly flexed at the knee. Then the upper leg, I will go and try to flex it at the knee and the hip. I have to first make sure the area which is to be mobilized. That can only be done after radiographic evaluation. I put my hand and feel the movement. I do the flexion of the hip and the extension, and the point wherein I feel on my right hand that that particular segment is locked. I mean, you will feel that, but when you move the leg, you will feel on your, when you move the left leg, that is the left leg, up and down, you on the your right hand, beneath your right hand, you will feel at a particular point that area is getting involved. I mean, there is a particular movement, and you will understand that at that position you are supposed to lock your knee. So that is to be locked. So after that, what we do is we do go for rotation of the upper spine. That is the lower shoulder, that is in this case the left lower shoulder, it will move forward, and the right upper shoulder, it will be rotated away from me. This is the position that I was talking about. First we have isolated the movement by isolated segment rather by locking the knee in that particular position. Then we rotate the spine, and after that we ask the patient to take deep inhalation, and when he inhales, I will hold his arm in my arm, I mean lock it in this particular position. After locking, I will isolate the particular segment which was supposed to be mobilized, and this is that particular area, and I ask the patient to take a deep inhalation. When he takes the deep inhalation, and we tell him to go for fast exhalation. When the patient exhales very fast, we go for rotation, and again you will feel a popping sound sometimes. Even if you do not feel a popping sound, it is not necessary that you always feel a popping sound. Still, the mobilization would have been expected to have been done. This is an alternative for this rotatory mobilization. If you are not able to grapple up with the particular technique of holding the arm, I mean isolating and all that stuff, the minimum thing that you can do is isolate the movement, rotate the lower segment, then use one hand on the shoulder and the other hand will be on the knee, and then you simultaneously give thrusts to the upper and the lower segment. I mean, I already exceeded the time limit. It's 22 minutes. I was supposed to be finished in 20 minutes. Still, try to cover it in time. Understand, practically it is very difficult to make you all understand, but hope that you have taken the gist of it, and hope to see you soon, guys. And thank you for the organizing committee for giving me this chance. Again, lots of love. I have never missed till now, I suppose. Have I missed? No, I don't think I have missed upcon, and this time also I have not missed upcon. It's the love that speaks. Thank you so much. God bless you all.
Thank you everyone for giving your time in listening our experts in different topics. For the valedictory, I would like to call Dr. K.N. Namalai sir, Dr. Georgie John, and for presenting the vote of thanks, I would like to call Dr. Rahul Parashar.
नमस्कार दोस्तों, upcon Physio Gen Next Gen 2018. I am remembering those days. I was there, but due to COVID, it is very unfortunate that I could not be there. But still, they are not leaving this conference unspoken. During the COVID time also, they have taken these challenges up and really they have did a great job over here. These 2 days, I think 31st and 1st, you must be enjoyed, and you must be listen to a lot of good speakers, and you must have earned a lot of knowledge, I think. So this is going to continue, and it is going to rock, and my best wishes for this conference to continue more and more number of years together. And really this amalgamation concept is it's a kind of a fusion of knowledge. Every year it is required to update, and especially during the COVID times, during these challenging times, they have taken this to the next level of cyber level, and they are doing it in the online, and really it is an amazing work. I would like to congratulate Sudeep for this wonderful work, Rahul, Sanjay Shukla ji, Renu Giri, who took enough time to take this during this challenging situation, and Pawan ji and Mishra ji, and the great regards for patterns like R.K. Meena sir, and the great and none other than UP means, if we don't forget, Ashok Sharma ji is a senior and he is a legend living here, and all his blessings are there. And apart from that, I want to just, with my corner of my heart, I would like to thank for the blessings of our great President Sanjeev Jha sir, and our Vice President Reddy sir is also a pattern of this conference, and our Honorable Treasurer is doing a great work over here, and she is also an inspiring personality. She is a part of this, and I am really happy, and the best wishes for forthcoming conferences. Hope next year maybe I will be there. Thank you so much, and best wishes.
Hi everyone. The 2 days virtual conference upcon Physio nexgen 2020 come to an end. The organizers put their heart and soul to bring the best resource person from all over the country to share their expertise and knowledge to all the participants who attended this conference. And I am sure all the participants also feel the same. They gained immense knowledge by attending this conference. For last so many years, upcon became a brand name in the calendar year of physio conferences in India. On this time, on this pandemic COVID-19 situation, it was a difficult task for the organizers to conduct this conference, but they taken the challenge with both hands and bring the best out of this, and this conference turned out to be a huge success on the virtual platform. For the pillar behind this conference, upcon Physio nexgen 2020, the chairperson Dr. Sudeep Saxena sir, Dr. Rahul Parashar sir, Dr. Sanjay Shukla sir, Dr. Renu Giri ma'am, Dr. Pawan Seni sir, and Dr. Ubendra Misra sir, and the whole team of the upcon Physio nexgen 2020 deserve a big applaud. And personally, I was part of all the previous upcon events, and this time too I am blessed to be part of this great virtual conference, and I am sure in coming years the upcon team will bring so much surprises and more color to this conference, and it will be making a milestone in the history of conferences in India. From bottom of my heart, I thank all the organizers and all the participants who taken the time and believed in this upcon team and attended and make this one a huge success. Thank you.
Good afternoon on behalf to all organizing team of UP Confusion. I take the honor thank all part of this program. Thanks to all veterans, Dr. Sanjay, Dr. Suresh, Dr. Navalai sir, Dr. Vasne, Dr. Joji, Dr. R sir for guiding us throughout the program. Thanks to all respected speaker who will enlighten all of and delegates with vast knowledge. My special our technical Mr. Rahul Saxena, Mr. Rashi, Om Physio. Without them, the program would not be possible. This year, due to ongoing pandemic, we were not able to deliver an conference. I hope the next year we will accumulate once again on a physical form. And then Radhe Radhe. Results of poster of paper presentations. Poster presentations, Dr. Kajal Soni first, Amit Pachori second, Riya Pandey third. And result of paper presentation seniors, Dr. Sharda first, Dr. Savarna second, Dr. Gijanjali Sikka third. Result of for paper juniors ongoing on Madhuri first, Mudit Yadav second, Sarita third. Each certificates of participant will be sent to all registered delegates, speakers, paper and poster presentation on the email address they have entered in their Google form with 1 week. Thank you.